You can start, ma'am.
Okay, thank you. We are extremely honored to welcome all of you to this Foxy ICOG online certificate course on oncology, which will be held from today, the Wednesday, the 4th of December, till Friday, the 6th of December, for 3 days from 4 to 7 p.m. And we are honored to welcome the President Foxy, Dr. Jaideep Tank, Chairperson of ICOG, Dr. Parul Kotadwala, the Secretary General of Foxy, Dr. Madhuri Patel, Dr. Sheila Mane, the Vice Chairperson elect, and Dr. Sarita Bellarao, the Secretary of ICOG. And I am one of the series conveners along with Dr. Parag Biniwale, who is the chairperson elect of ICOG. I'd like to welcome the conveners of the course, Dr. Sarita Shamsundar, Dr. Priya Ganesh Kumar, and Dr. Anjana Chauhan, and the coordinators, Dr. Nilanchali Singh, Dr. Varsha Prapanna, Dr. Janani, Dr. Suganya Sevuha Perumal, and Dr. Sapna Kumar, all the esteemed chairpersons who have joined today, the speakers, as well as the delegates. I would like to welcome all of you. And before we go on, may I request Dr. Ms. Neelima from ICOG to play the invocation song so that we can start on an auspicious note. Gauri, play a prayer song. I will share all these slides. You just play there, then you can this thing. Thank you so much. I will just introduce I would like to welcome Dr. Sheila Mane, the ICOG Vice Chairperson, and she is from Bangalore Society, has been the past president of BSOG, and she's won several awards, and she's been honored with several citations throughout her career. And she's also known as a PPH lady, and as she has won the Best Committee Award for Megrudara Hansotia Award for Safe Motherhood Committee work. And I'd like to welcome Dr. Parag Biniwale, the series convener for the certificate courses. He's a chairperson elect of ICOG, and he will be chairperson in 2025. He's a PG teacher and unit head from Kamala Nehru Hospital, Pune. He's been the president of Pune Society in 22-23, and he's been a president of the Menopause Society of Pune. Welcome, Dr. Parag. Dr. Parul sir will be joining a little later. Sir is the chairperson of ICOG for 2024.
Sorry to interrupt you, ma'am. Sir, I joined.
Okay.
Already joined.
Yes, sir. Thank you, sir. He's an endoscopic surgeon and consultant gynecologist, and he's the professor and head department of OG at Sai Institute of Medical Sciences, Ahmedabad. And he's been the vice president of Foxy, president of SOGOG, president of Ahmedabad Society, and also he was a chairperson of the scientific committee of ICOG in 2017. May I request Dr. Parul sir to say a few words before we start the program?
Well, I welcome you all for the last certificate course of our tenure. And I'm sure that the next team also will continue because this is one of the signature program of ICOG, very popular with colleagues. And you will always notice that highest attendance has been noted for this program. I compliment you, Dr. Charmila, for conducting this program during the entire year. And this one is on oncology, and oncology is getting more and more focus these days. And I'm sure that all the participants would benefit immensely from this program. Let us get on with the program. Thank you very much for all your inputs.
Thank you so much. Parul sir. And this whole year has been a wonderful year because of your very, very inclusiveness, and all the governing council members have benefited by your largesse. Thank you so much for the opportunities. Now we'll go on to the introduction of the rest of the faculty today. Dr. Jaideep Tang is the president of Foxy, and he's been the Secretary General of Foxy. Before that, he has held several administrative posts. He'll be joining later. Dr. Sunita Tandulwatkar is a president-elect of Foxy. She'll be in president 2025. She's the head of the department at IVF and endoscopy unit of Ruby Hall Clinic, Pune. When she joins, madam will be saying a few words. And Madhuri Patel, madam, has joined Nilima.
Madam, you have to come office.
Okay.
I will.
Yeah.
Convene, yeah.
It's an honor to introduce Dr. Madhuri Patel, the First Lady Secretary General of Foxy, and also the Editor-in-Chief of the Journal of Obstetrics and Gynecology of India, Jogi. She's held several administrative posts in Foxy before she became the Secretary General of Foxy, and she's won several awards and has been cited by.
हाँ वो मच्छर के लिए वो धूप दाना दे के आया था, काम कर रहा है कि नहीं?
Please mute them, Nilima. And she's been awarded the Ganatara Charitable Medical Center Award in 2020-23, and also the DC Datta Prize for the Best Foxy publication in the year 2024. And Dr. Janmajaya is the next guest of honor today. He's the Vice President of Foxy for this year. Yeah, he's a professor at the Department of Oncology at AH Postgraduate Institute of Cancer, Cuttack, Odisha. And he has held several post-organizational positions both in Foxy and IMA. And he has won several awards, which include the Best Secretary, State Secretary of IMA in 2016, 17, and 18, 19. His field of interest on oncology and endoscopy. Dr. Sarita Ballarao is the Secretary of ICOG. She has been the President of Mumbai Society in 21-22, Joint Secretary of Foxy in 2017, and she's been the Chair of the Quiz Committee of Foxy in 2009 to 2011. So before we start, I would just talk a little bit about the certificate course. The certificate which will be issued to the participants who attend on all the 3 days, and it's compulsory that you put your attendance for all the 3 days. A Google link for MCQs will be sent a little later now. And anybody who has attended on all 3 days and passed with 50% marks on each day, the post assessment, which is kept after the day's program is over, will be given a certificate, and the certificate will be issued within 1 month. And please remember, it's just an acknowledgement of attendance, and it does not certify on your skills and experience. And all this material will be uploaded on the ISOG website later on, and you can go through that. The conveners for today is Dr. Sarita Shamsundar. She's a professor and unit head of Oncology at Vardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi. She's been a board member of International Federation of Colposcopy and Cervical Pathology, and she's organized the conference in 2021. This is the chairperson of the Oncology Committee for Foxy in the coming 3 years. And she's held several positions as an editor, and she's won several awards. Welcome, Dr. Sarita, for the program today. The next convener will be Dr. Priya Ganesh Kumar, and she'll be doing it later on. And she's been the chairperson of the Oncology Committee of Foxy for the past 3 years. She's authored several books and has got several publications to her credit, and also been awarded and has got lots of recognitions to her credit. She's done a mentorship and training for WHO, IARC, IFCPC, colposcopy and cytology course. And also she's a Foxy colposcopy course conductor and a master trainer for cancer prevention under the NCD Ayushman Bharat project. And she also holds a PhD, she's also a PhD guide. The third convener will be Dr. Anjana Chauhan. She's a consultant gynec cancer surgeon from Gujarat. And she has initiated the HPV awareness in Gujarat, and also the initiator of the first HPV clinic, the first of its kind in India. She's a preventive gynec oncologist, and she's been the chairperson of the Oncology Committee of the Indian Menopause Society. We will welcome all the 3 conveners and the coordinators, which will be introduced by the convener of today. That will be Dr. Sarita Shamsundar. May I request Dr. Sarita to take over, please?
Madam, Janmedaya Mahapatal sir has joined.
Okay.
Just for welcome, yeah.
May I request Dr. Janmajaya to bless the gathering before we start? Janmajaya.
Madam, Dr.
Good
Sunita ma'am
afternoon,
also joined.
Sharmila.
Okay.
Good afternoon, everyone. Respected President Foxy, Dr. Jaideep Tang.
Sir, one second.
President-elect
Sir,
Dr.
one second. Nilima, please mute the other people. Please mute the other people. There's a disturbance.
President-elect Dr. Sunita Tendulkar, Chairperson ISOG Dr. Parul Kotadala, Secretary General Foxy, and Editor-in-Chief Jogi Dr. Madhuri Patel, Vice Chairperson ICOG Dr. Sheila Mane, Secretary ICOG Dr. Sarita Valerao, Series Convener Dr. Parag Binwale, Chairperson elect ICOG, Dr. Charmila, Vice President Paksi, and conveners Dr. Priya Ganesh Kumar, Dr. Sarita Samsundar, and Dr. Ranjana, and the coordinators Dr. Nilanchali Singh, Dr. Varsha, Dr. Janani, Dr. Suganya, and Dr. Sapna. First of all, I am congratulating Team ICOG for conducting regular ICOG course on different subjects. It is a great pleasure that today ICOG is conducting a 3-day certificate course in gynecology oncology. It will be covering major subjects in gynec oncology for general practitioners. The course has covered many aspects from cervix to endometrium to ovary to vulva. It will surely be a great learning experience for all participants and help them in their day-to-day practice. Thank you all. Long live Aishwarji, long live Pakshi.
Thank
Thank you,
you.
Janmajaya.
Yeah, thank you, Janmajaya sir. May I request Dr. Sunita madam to say a few words and bless the program before we start. Sunita madam. Madam is joined, no?
Yes, yes, Madam Enter.
Can you give her a call? I think.
Yeah. Okay.
Sunita madam.
You said hi on the group. So she's
Ah.
here. Oh, she's here.
Yeah. Sarita, can you give her a call? I think she must be thinking of it.
I can. Okay, one second.
Ah, madam is joined.
I'm
Madam.
here.
Yes, ma'am. Please, ma'am.
I was muted, so I just disappeared.
Okay. Sorry, ma'am.
So first of all, is congratulations here. The way ICOG is functioning, doing this all online teaching, training, it's a huge task. And Charmila, you, the professor, the perfect academician. Sarita, thank you so much. What is important is not only meticulously planning the scientific program for our all students, but also ensuring that the right faculty we get them in so that everyone is benefited with the most advanced thing. And I'm so thankful that you involved me. I get to see you all here. And my best wishes are always there, and keep on doing such a good job, even with Dr. Parag next year when he will be the ICOG chairperson. Dr. Janmejaya, I missed
Yes.
your conference, but nevertheless, there is always some.
We also missed you very much.
Thank you so much for having me, and I invite every one of you to AICOG 2025 January to Mumbai.
Yes.
Be there.
Yes, sure.
Thank you.
Thank you. Thank you so much for this, that very, very encouraging words, ma'am. Thank you so much.
Thank you.
Yeah. Now we'll start the academic session. May I request Dr. Sarita to take over, please?
Good evening, everyone. And thanks to ICOG, Dr. Parul Kottawada, and Dr. Parag Biniwala, Dr. Charmila, Dr. Sarita Bhalerao, and the Foxy for this invitation to be a convener for this for the day 1 session of the ICOG oncology course. Yes, cancer is the new pandemic, and everybody, we all gynecological cancers are the commonest cancers. Actually, cancers in women are #1. So that's #1 cause of mortality especially in our country. So we as gynecologists, we come across gynecological cancer so often in our clinics, and we must know how to actually do a basic workup and the management. Of course, maybe the final the aspects of the management can be dealt by the cancer surgeons, but the basic workup and how to do an assessment of the case, how to stage the disease is the most important, the first step. Which every gynecologist has to learn and has to carry out. So the course has been divided into 3 days for 3 different organs. So the commonest cancers that we see, the ovarian, cervical, and endometrial, and the vulvar cancers. So the first session today is on ovarian cancer. Again, we see that so often in our clinics. So we are going to talk about we are going to go from the basics actually, going from what is the role of screening for ovarian cancer, what are the tumor markers, which tumor markers are to be done in which case, how to interpret imaging, when to do an ultrasound, when to do an MRI, when to do a CT. These are the basic things, and these are being dealt by the core the subject specialties. Like for imaging, we have a radiologist. For tumor markers, we have a professor of pathology, and also for planning the management of the ovarian cancer and surgery and cytoreductive surgery, we have Dr. Rama Joshi, who's an gynae oncosurgeon, and we also have medical oncologist who's going to talk about the chemotherapy and the various other methods of chemotherapy that have come up recently. And so I now we
Before we
will show
start,
you.
Dr. Sarita
Yeah.
has joined. We will request her to
Yes,
say a few
yes.
words. Sarita,
Yes, ma'am.
we request you to say a few words
Yeah,
and
no, thank you, but I don't have very good network. So, and I just welcome all of you, and I wish all the best to the cause. And I'd really like to thank our series conveners, also Dr. Parag and Dr. Charmila, and our three very, very dynamic conveners, Dr. Sarita, Dr. Priya Ganesh Kumar, and Dr. Anjana Chauhan. Yeah, thank you, and you can start now with the pre-test.
thank you, Sarita. Thank you so much. Sarita, you need to introduce a coordinator for the day, and
Yes,
then
yes.
we'll start the pre-test. You
Yeah,
want
so
the
the
CV? Do you want me to flash the CV?
Yes, you can.
Yeah, okay.
You don't mind. So the coordinator for today is Dr. Nilanjali Singh. She's a young gynae oncologist from AIMS, Delhi. Again, she's done a fellowship in gynae oncology from Canada and has won various awards and published so many papers. So she's a very active young gynae oncologist from Delhi. So she will be the coordinator for today.
The other coordinators also you can introduce so that we need not do it
Okay.
again. Okay.
Okay, Dr. Varsha Prapanna, she's a consultant gynecologist and credentiated menopause practitioner and joint secretary of Baroda Obs and Gynae Society and secretary of the Vadodara Menopause Society, and has been a quiz convener in the Indian Menopause Society. Welcome, Dr. Varsha. Dr. Janani is also the coordinator, and Dr. Suganya Sevuga Perumal. Dr.
Sevuga
Sapna,
Perumal.
yeah. Dr. Sapna Kumar is the consultant obstetrician gynecologist from Matrutva Hospital, Tarsali, Vadodara, practicing since 10 years. And also she has been a topper and conducted many awareness sessions for schools and on PCOS. She has a special interest in fertility and sonography and menopause. So welcome, Dr. Sapna.
So we'll start with the pre-test, and I request Neelima to put the timer as well as the link.
Yes, ma'am.
It is for 10 minutes. There'll be silence during the pre-assessment, so there will be no audio. So don't think that the program has gone off. You have to wait for 10 minutes before we start.
Gauri, put the link in chat box also.
Sarita, you can take over today.
Yeah. Okay. So after this pre-test, I will now Neelanjali will take over. We'll begin with session 1, which is going to be on the basics about on the screening, on tumor markers and imaging. So over to Neelanjali to introduce the chairpersons and the speakers.
Yes, ma'am. So a very good afternoon, everyone. So let's begin the scientific session of the first day of ovarian cancer ICOG program. So I invite our chairpersons for the first session. Our first esteemed chairperson is Dr. Vinita Singh. Madam is Associate Professor, Department of Obs and Gynae, NMCH Patna. She's consultant Kara Hospital IVF Center, and she's currently holding the post of East Zone Coordinator FOXY and Governing Council Member ICOG FOXY 2023-24. And ma'am has various credits and awards to her. Our second esteemed chairperson is Professor Ashra Batra. Madam is the National President NARCHI 2022-24, Governing Council Member FOXY ICOG Elect, Chairperson IHCP Division Stillbirth Society of India, and member FOXY Project on Reduction of Caesarean Births. And ma'am has many awards and publications to her credit. She is a reviewer of multiple national journals and a master trainer WHO for RAC and RMC. Welcome, ma'am. Our third respected chairperson is Dr. Kiran Pandey. Madam is the chairperson of Medical Education Committee, FOXY. She's Professor, NHOD, Department of Obs and Gynae, GSPM Medical College, Kanpur. Madam is ICOG Governing Council Member 2325, President Kanpur Menopause Society, President UP State Chapter of Association of Gynae Oncologists of India 2024-26. And ma'am also has multiple achievements, awards, and research credits to her. We welcome you, ma'am. So over to our respected chairpersons to carry forward the scientific session.
I don't see any of them logged in actually. I called Dr. Achila. She may will be joining, but you can just, I think, introduce the speakers.
Right.
The first speaker.
So we move on to the first session, which is a lecture by Dr. Bindya Gupta on screening of ovarian cancer. Madam is a professor, Department of Obstetrics and Gynecology, UCMS and GTB Hospital, Delhi. She's a Commonwealth Scholar, Gynae Oncology from Birmingham Gynae Onco Center, UK. She's IFCPC IARC certified colposcopist. She has various publications to her credit, 120 publications. She has multiple awards, including the FIGO Prize paper. And she's a member of FOXY OGD Oncology Committee, editor of AOGD, Joint Secretary of India.
Thanks, Neelanjali. I think that's okay. And I'll share my screen.
Yes, ma'am. Whatever is said about you is less, but yes, welcome, ma'am.
Thank you so much. Can you see my screen now?
Yes, ma'am, we can see. Yeah.
Okay. So thank you very much. At the outset, thank you so much, Dr. Sarita, for making me a part of this program. It's an excellent academic activity, and I'm very sure that the delegates will and everybody will be very benefited with this activity. So my topic allotted is screening for ovarian cancer. So why should we screen for ovarian cancer? Because it is one of the most common causes of gynae cancer-related deaths worldwide, and majority of the cases of ovarian cancer are diagnosed at an advanced stage, and hence it is appropriately called the silent killer. And Globocan has predicted that the number of ovarian cancer cases and deaths will rise globally by 36% and 47% respectively over the next 20 years. So whenever we talk about screening, what we mean is that we need to identify an unrecognized or asymptomatic disease before it is actually taken its shape, or at least an early detection of the disease. So my lecture will be focused on what are the screening methods available for ovarian cancer. How do we do the risk assessment? Who are the ones who are at average risk or who are at high risk for developing ovarian cancer? What are the various trials done in this field? What are the recommendations by various societies? And some risk-reducing strategies in high-risk population, where I will discuss in brief. So coming to the screening methods which are available. So we have 4 major screening methods or tools which we can use, which are available. One is the symptom index. Then one is pelvic examination. Then the tumor marker, that is CA-125, and the use of sonography. So coming to the symptom index, it is called as the Goff symptom index. This is basically an index symptom complex which consists of these signs, which include bloating, an increase in abdominal size, feeling of fullness, difficulty in eating or loss of appetite, pelvic or abdominal pain, presence of urinary urgency or frequency, and weight loss. Now, if this symptom complex, it is persistent for more than 12 times in a month for less than 1 year, it is highly suggestive that this patient may have a high risk for developing ovarian cancer. And in the study, in a confirmatory sample, the sensitivity was 56% for early stage disease and around 80% for advanced stage. The specificity was at around 90% for women aged more than 50 years for this symptom complex. What about pelvic examination? Now, when we do a routine pelvic examination, does it indicate that this patient may have a high risk for developing ovarian cancer? Usually, when we do an examination, it is only the advanced stages we are able to diagnose with pelvic examination. And at this moment, till now, there is insufficient evidence to assess the balance of benefits and harms of performing screening pelvic examinations in asymptomatic, non-pregnant adult women for detection of ovarian cancer. So pelvic examination is not a good screening tool. In the PLCO trial, they found that the sensitivity was just 3%, but the specificity was 98%. So if you find nodularity in the pouch of Douglas, you find a ovarian mass, you find ascites, so that is definitely indicated that this person may have ovarian cancer, and usually they present in the advanced stages, but sensitivity is very low for the early stages. Now, coming to tumor marker, that is CA-125. CA-125 is we all know it's a glycoprotein, and it's the only US FDA approved biomarker for ovarian cancer detection, especially when we have cell masses evaluation. And the cutoff taken is 35. And for stage 1, only 50% of the patients, they have elevated CA-125, and it is only in the later stages up to 90% may have an elevated CA-125. The sensitivity is around 83% and the specificity is low, around 60%. And it is because it can also be elevated in various other benign conditions like fibroids, endometriosis, and even in normal menstruation and conditions like tuberculosis. Also, other cancers like breast, bladder, liver, etc. may also be associated with elevated CA-125. So it is not a single value, but it is a serial CA-125. If it is done in high-risk population, it may have some positive predictive value of up to 40% for detection of invasive ovarian cancer. And this is called as the ROCA, or the risk of ovarian cancer algorithm. And this ROCA study is basically in which we compare a woman's longitudinal CA-125 pattern to the change in the point profile of the woman who had developed cancer in the previous trials. So in CA-125, if suppose there's increased serial elevation, that is more important than one single value of CA-125. And the combined specificity of ROCA followed by TVS for referral to surgery for detecting invasive cancer was almost very high. So especially in the high-risk population. And overall, a positive predictive value for ROCA is just 40% for detection of invasive ovarian cancer. So if you're doing CA-125, it is a serial value which is more important than a single value. Now, coming to transvaginal sonography, during screening, it's basically the appearance of the ovary, the morphology, and the ovarian volume, which is important. But then the limitations of TVS are that many aggressive tumors, they may metastasize before reaching a sonographically detected size. There is a subjective nature of assessment and interobserver variability. In hysterectomized women, obese, and tubal-ligated women, there may be difficulty in visualization of ovaries, and there can be poor visualization of the fallopian tubes, and if the tumor is less than 1 centimeter. Now, various new techniques have been evolving. However, still they're under research settings only, and as of now, it is not a very good tool for routine screening of the of ovarian cancer. So these are the tools which are available. But how do we assess the risk, that which is the woman at a high risk or which is the woman who's going to is at average risk? Now, in the general population, the lifetime risk for developing ovarian cancer is around 1.3 to 2%. There is various lifestyle-related factors like obesity. Then it was found that the use of talc, cigarette smoking, alcohol use, they were associated with increased risk. The gynecological risk factors are endometriosis, use of hormone replacement therapy, nulliparity, use PCO, history of PCOS, infertility. These are certain risk factors for for developing of ovarian cancer. But there's certain protective factors. They found that the long-term use of low-dose aspirin, use of ocipils for more than equal to 10 years, parity, breastfeeding, there are certain protective factors. Then, in fact, if there's a history of BSO with salpingo-oophorectomy, obviously that is protection against ovarian cancer. And certain studies also said that tubal ligation may also have have some protective impact on the ovarian cancer incidence. So who are the high risk, who have more than 10% risk? These are the ones who have a high risk of having hereditary ovarian cancer. And these constitute overall around 5 to 15% of overall incidence of ovarian cancer. These women, the incidence of ovarian cancer is at an earlier age, around 48 to 51 years, vis-a-vis 60 years in a general population. The two important genetic predisposition are the BRCA genes, that is BRCA1, which is responsible for 44% of the cases, and BRCA2, which has an incidence, which is responsible for 17% of hereditary ovarian cancer. Other 10 to 15% maybe because with the Lynch syndrome, in which we have also coexistent endometrial and colon cancer. Then other minor variants are the RAD genes, the BRIP, and the PALB2 genes. And then you have certain low penetrance genes also. This is a subset of women which we have to pick up, which we have to screen, which we have to follow if we want to diagnose ovarian cancer early. Now, various risk assessment tools are there for prediction of ovarian cancer. The CanRisk model is available on the website. It is, you can feed in certain particulars and it will give you a risk calculation that if there's a more than 10% risk of having a hereditary ovarian cancer, then certain molecular marker combination methylation profile, that is FORCI, is a prediction tool. Then various family risk tools are also available, like Ontario Familial History Assessment Tool, Manchester Scoring System, Pedigree Assessment Tool, etc. is available. But what does NCCN say that who should be tested? There are various, it has been given by NCCN, but just to have a gist of it, it is if a family member is there with a pathogenic BRCA1, BRCA2 variant, those family members at a higher risk of developing a hereditary ovarian cancer. Then if the woman has a personal history of breast cancer, which is triple negative, or if she's a young woman less than 45 years, or if there's a close relative with a breast or a high-grade prostate cancer, those are the ones which have a high risk of developing the ovarian cancer. If there's a history of ovarian cancer in personal, or if there's a history of ovarian cancer in a first-degree relative, male breast cancer, metastatic prostate cancer, or a pancreatic cancer, those are also the people who are candidates for hereditary testing. So these are the ones who are the candidates for BRCA1, BRCA2 testing. And if they are positive, then these are the women which we have to look forward to, because they are the ones who need to be screened, who need to be risk reduced, because they are the ones who are harboring more than 10% risk of developing the ovarian cancer. Now, what is the evidence? What do the trials say which have been done on ovarian cancers screening? Now, these are the certain trials which are done in general population, and those are done in there are trials which are done in the high risk population also. So let us look at the trials in the general population. So these trials, first, most important is the UK talks, that is the UK collaborative trial of ovarian cancer screening. In this, they used the screening strategy was the multimodality screening, in which they used a longitudinal ROCA algorithm followed by TVS and repeat CA125 as and when required. Another screening strategy, which was a serial TVS screening strategy, was used. So two screening strategies were used and compared. And let us see what the results were at 11 years of follow-up and at 16 years of follow-up. So where they found that in intervention and control arm at 12 years, there was a non-significant reduction in mortality, and there was no difference in detection of stage 1 and 2 epithelial ovarian cancer. So in an average risk population, the multimodality screening strategy did not have any implications. And what happened at the further follow-up, they found that at 16 years, when they again compared the results between the intervention versus the control arm, they found that in each group, only 1% of women were diagnosed with ovarian cancer. But what they found that screening was associated with a stage shift. That is, there was an increase in the incidence of stage 1 and 2 disease detection was higher in the screened population vis-a-vis there was a decrease in the advanced stage detection. So this also then translated into better surgical resection rates in the screened population. But This was only a surgical advantage. Overall, there was no significant reduction in the ovarian and tubal cancer deaths in the MMS arm or the ultrasound arm compared with the no screening group. So the interventions, both of them, there was no mortality benefit, but yes, there was a definite advantage of detecting the cancer in the earlier stages and a better R0 surgical resection rate in the screen population. This was the long-term analysis of the UK-CK Talks trial. What about the PLCO trial? This was another trial in which they again used a combined strategy of CA125 and TBS. They also found no reduction in mortality. Similarly, the Japanese study and the Kentucky study also, they also found that there was it was a very small one. This was a single center which we do not take into consideration. But majority of the studies, this is the entire gist. This is a very heavy slide, but what I want to show that all the societies have said that evidence does not support routine screening in the average risk population. So in asymptomatic average risk women, there is no need to screen the asymptomatic average risk women. So do not do it, because there'll be more harms than benefits. Now, coming to high-risk population, these are the ones who have more than 10% risk. These are the ones which may have a hereditary risk predisposition. This was a UK familial ovarian cancer screening study, that is UK FOX. They also used the annual combined strategy, but this again said that this just improved the optimal debulking rates, but again, there was no mortality benefit. And the phase 2 also said that there was a significant stage shift, significant increase in low volume disease detection, significant R0 detection rate, and also there was a decrease in the use of neoadjuvant chemotherapy. But again, this did not translate into a mortality benefit. Then the US Genetic Cancer Network also, they said that there was an increase in the detection of the early stage disease compared to the historical BRCA control. So significant downstaging was definitely there when this modality was used in the high-risk population. So in high-risk individuals, they said that those who are not undergoing any risk reduction surgery, then annual CA125 and TBS should not be undertaken for women at high risk, but for genetic risk, the women they can undergo surveillance. The individuals with a strong family history of cancer should be referred for counseling and testing for an ovarian cancer susceptibility gene, and the overall pretest probability is more than 10%. And once it is diagnosed, cascade testing should be offered, and they should be offered risk reduction rather than the screening protocol. But yes, if the woman does not want to undergo risk reduction strategy, we can offer her the screening program, but at the same time, we have to tell her that it will not translate into a mortality benefit, only that we will be able to downstage the disease if it is detected. Now, coming to preventive strategy, a bit about preventive strategy. The risk reduction benefits are there. A risk reduction bilateral salpingo-oophorectomy can be offered to BRCA1, BRCA2 pathogenic variants. So BRCA1 carries at 35 to 40 years of age, and BRCA2 at 40 to 45. And even in the lower other genes, again at 45 to 50 years of age can be done. In women with PALB2 variants, they can be considered in postmenopausal women. And in Lynch syndrome, it should be combined with a hysterectomy. Risk-reducing salpingectomy alone is not recommended. It is only for a clinical trial followed by delayed oophorectomy, and it is right now a lot of trials are being undergoing. And women desirous of fertility preservation, short-term surveillance can be offered to them with the strategy of TVS and CA125. At the same time, you have to tell them that this does not have any mortality benefit. Only we can diagnose the disease at an earlier stage. It will only help in downsstaging. Now, RSS of benefits, as I said, it is an opportunity for gynecological risk detection in the high-risk women. And the RSSO protocol is that we basically have to survey all the organs. Biopsy should be taken from abnormal peritoneal findings. Cytology should be taken. And along with the BSO, removal of 2 centimeter of IP ligament should be there, and minimal instrumentation should be there. And we can use laparoscopy or laparotomy, and a CFIM protocol is used.
I'm sorry
In
to interrupt you.
pathology.
Your time is up.
Yeah, I'm just closing. And this is, I said, it is under the under trials only. And hysterectomy should be offered only in the one who have got the Lynch syndrome. So coming to the conclusion, none of the randomized trials have demonstrated a mortality benefit, and currently not women recommended to women at average population risk. In high-risk population, it has only shown a good performance and significant downstaging, but preventive strategies is recommended in women with a diagnosed genetic risk, and novel multi-cancer biomarkers are being investigated. So thank you very much.
Thank you, Bindya, for very nicely evaluating, the role of screening for ovarian cancer. It has a role only in the high risk, and what can be done to reduce the risk. Yeah, thank you so much for that excellent talk. So, Nilanjali, you can introduce the next speaker. Dr. Charanjit Ahluwalia. Okay, Dr. Charanjit is a professor and consultant, unit in charge of histopathology and cytology at Safdarjung Hospital and Bardhaman Mahavir Medical College, New Delhi. That's the same place that I work. And she has a teaching experience of 20 years, and the area of interest is gynecological cytology and oncology. She has a lot of publications. She's also authored a book. And the most important thing, she's a very good teacher. So I invite her to give a talk on tumor markers in adnexal mass. So what are the tumor markers? What is the role of the various tumor markers? So over to you, Dr. Charanjit.
I'll just share my screen. I hope my screen is visible.
Yes, ma'am.
Okay, so I'll be talking about tumor markers and their significance in ovarian cancer. Now, we know ovarian cancers are characterized by silent progression and late stage diagnosis, and 70% are diagnosed in advanced stage, and 5-year survival rate for advanced stage is only 30%. And if early detection is done, survival can be over 90%. Therefore, the tumor markers are very important, and these markers can be secreted by tumor cells or cells in the vicinity of the cancer cells, and they are valuable tools for diagnosis and management of ovarian cancer. Tumor markers can be detected in blood, saliva, and urine. And the tumor markers can be hormones, they can be proteins, they can be enzymes, oncogenes, receptors, and antigens. And as we see here, screening and detection, monitoring treatment response, assessing tumor progression and prognosis, and identifying molecular targets for novel therapy. These are the applications of tumor markers. Now, we all know about ovarian tumors. There we have epithelial ovarian tumors, which constitute 90%, an important associated tumor marker being CA125, CEA, and HE4. Then in sex cord stromal tumors, inhibin and various other tumor markers are there. For germ cell tumors, we have alpha fetoprotein, HCG, and LDH, and tumors with metastasis in the ovaries is associated with elevated CA19.9, especially if metastasis is from hepatobiliary or upper GI tumors. So now looking at the first tumor marker in ovarian cancer, this is CA125, which is a glycoprotein that is produced by MUC16 gene. And the upper limit of this marker in the blood is 35 units per ml for both pre and post-menopausal women. Now, this tumor marker has been being used for past 3 decades, primarily for diagnosing ovarian cancer, monitoring treatment response, and detecting recurrence. And this biomarker, it is elevated in 90% ovarian cancers, and it has a sensitivity of 50 to 60% and a 90% specificity in early stage post-menopausal women. And it has been endorsed by FDA for evaluating treatment response and monitoring in ovarian cancer patients. Now, if we look at it as a prognostic marker in treatment outcomes, the high levels, that is more than 35, indicates residual disease, reduced chemotherapy sensitivity, and high tumor burden. Then in patients who have undergone surgery, the gynae cancer subgroup, it recommends that a person will be said to be in remission post-surgery if there is more than 50% decrease that is sustained for 4 weeks. And a person will be called a complete responder if the levels come to normal. Then if the level doubles within 1 week interval, then the patient probably has a recurrence. Then in advanced ovarian cancers, chemotherapy response can also be assessed using CA125 levels. So decline and normalization to below 35 units per ml by cycle 3 indicates favorable prognosis, and decline after neoadjuvant chemotherapy predicts positive debulking surgery outcome. However, CA125 has a few limitations. It is not a reliable marker for diagnosis and screening, especially in premenopausal women, because of the false positives and false negatives. The false positives, this may be elevated in a number of benign or inflammatory conditions, and therefore it is less accurate in reflecting tumor burden because it can be secreted by, and also it's less accurate in reflecting tumor burden because it can be secreted by non-tumor cells in an inflammatory environment. Then false negatives, 20% of epithelial ovarian cancer patients may not show an elevated CA125 levels, and sometimes people with autoimmune diseases who have circulating immune complexes, lower CA125 concentrations may be there because of binding of antibodies with the detection system and thus inhibiting accurate detection. Now, another very important FDA-approved tumor marker is HE4. And this HE4, it's a glycoprotein produced by WFDC gene, and it acts as a serine protease inhibitor. It is picked up in the blood and urine of patients by ELISA, which is commonly available, and FDA has approved the use of HE4 for monitoring patients diagnosed with ovarian cancer. However, this has been approved by FDA. However, there is a caution. Its use in the screening of asymptomatic early stage cancer is not recommended. Now, a cutoff value for premenopausal women is 70 picomoles per liter, and postmenopausal is 140 picomoles per liter. Also, this marker HE4 exhibits overexpression in specific ovarian cancer subtypes with 100% occurrence in endometrioid tumors and 93% in serous ovarian tumors. And it can also help in differentiating benign from malignant lesions. Now, the use of HE4 as diagnostic marker, if you compare it with CA125, it has the highest sensitivity and as a very high specificity, particularly in women below 50. And high levels of HE4 predict a poor prognosis with a higher mortality, shorter progression-free and overall survival, and poor surgical outcome. And in monitoring treatment response, higher levels may be associated with platinum-based chemotherapy resistance, recurrence, and residual tumor. Therefore, now combining HE4 with CA125, combining these two are best for monitoring treatment response and survival with the highest sensitivity, and can differentiate invasive ovarian cancer from benign neoplasms. So now there are a number of algorithms that are available for assessing risk of ovarian malignancy. One such algorithm is ROMA, or risk of ovarian malignancy algorithm. This is a diagnostic tool which is used to detect or look for the used to assess the likelihood of ovarian cancer in women presenting with pelvic masses. And this ROMA algorithm takes into account the menopausal status, the CA125 levels, and HE4. And this has high sensitivity and specificity for premenopausal women. In premenopausal, high risk of malignancy is indicated if the value is more than 13.1%, and in postmenopausal if it is more than 27.7%. Another such index for assessing, or algorithm for assessing the likelihood of a pelvic mass being malignancy, is risk of malignancy index, which take into account radiological findings, that is ultrasound score, menopausal score, CA125 levels, and tumor size, and thus gives a risk for, assesses the risk of a mass being malignant. Then another tumor marker is CA15.3. It is elevated in a number of cancers, in 45% cancer patients, especially when the cancer becomes advanced, and also in ovarian cancer with a cutoff level of 30 units per ml. And it can be used for residual tumor detection, monitoring tumor response, and disease progression during chemotherapy. Now, CA 15.3 itself just is not sufficient. Again, combining it with other markers like CA 17.4, which is basically for pancreatic cancers, but also elevated in ovarian, with CA 15.3 and CA 125 improves the sensitivity. Now, there is a model called artificial neural network model. Now, what is this artificial neural network? It's a computational model which is inspired by the way the neurons work in our brain to process information. Now, these artificial neural networks, they are a part of machine learning and deep learning, and they have been applied in ovarian cancer also, because these artificial neural networks, they can analyze multiple biomarkers like these biomarkers like CA125HE4, then imaging data and clinical factor to improve or to provide early detection of ovarian cancer. So multiple markers along with clinical data and radiological findings all can be used to provide for early detection, and it has highest diagnostic power than CA125 alone, and this artificial neural networks are effective in stage 1 detection of ovarian cancer. The next important tumor marker is CA 19.9, and this is again, it's a blood group antigen secreted or expressed on the surface of cancer cells, and it is found in the blood. And it is a marker for pancreatic cancer, gastric cancer, and hepatobiliary malignancies also, but is also elevated in epithelial or in mucinous ovarian tumors. So CA 19.9, CA 125, and CEA, along with tumor size, helps in distinguishing benign, borderline, and malignant mucinous ovarian tumors. So CA 19.9 is for mucinous ovarian tumor with high sensitivity and specificity. Then beta HCG. We know beta HCG or human chorionic gonadotrophin, this enzyme has, or this hormone has different isoforms, and very important is the beta subunit which we use. And normal HCG levels, beta HCG levels should be less than 5 milli international units per ml. Now, beta HCG is secreted by tropoblastic cells, and it is elevated in germ cell tumors, non-seminomatous tumor, melanoma, carcinoma, breast, ovary, GIT, and lung cancer. Now, its role in epithelial ovarian cancers. So, increased beta HCG levels are associated with advanced stage of epithelial ovarian cancer, metastatic ovarian, if ovarian cancer metastasizes somewhere, these are elevated, aggressive clinical types of ovarian cancer, large tumor size, poor differentiation, and high-grade serous carcinomas may also have this. Then it is for prognostic, it is an independent, unfavorable prognostic factor for overall survival, and with luteinizing hormone, both if the receptors for these are expressed, then better outcomes in well-differentiated tumors, because well-differentiated tumors will express receptors for them. So the beta HCG levels are measured in the blood, whereas the receptors can be detected in the blood as well as in the tissue. Now, another tumor marker is inhibin. Now, inhibin is produced by the ovarian follicles, and we have two types of inhibin, inhibin A or alpha and beta inhibin. These are the two subunits, and they are detected in the serum by radioimmunoassay or inhibin ELISA. And in normal postmenopausal women, the levels are almost undetectable or very low, whereas in case of premenopausal women, in premenopausal women, variable levels during different phases of cycle. And we also know that serum inhibin levels are a part of, alpha inhibin is a part of quadruple test for prenatal screening of Down syndrome. Now, what is the role in epithelial ovarian, in ovarian tumors? In inhibin level, inhibin is a diagnostic marker for granulosa cell tumor, Sertoli Leydig cell tumor, and mucinous ovarian tumors. And in granulosa cell tumor, monitoring treatment response and assessing disease recurrence, all are roles of inhibin. And serum level of inhibin and CA125 in marker for epithelial tumor, we know improve the specificity for identifying the granulosa cell tumor from 82 to 95% in postmenopausal women. So, however, limited use in premenopausal women and early stage detection. Then alpha fetoprotein is a marker related to embryonic development, that is yolk sac, and we know it is for diagnosing germ cell tumors. It's a marker of germ cell tumors of the ovary and testis and liver tumors. In addition, it serves as a marker for cancer detection and rarely in epithelial ovarian cancers also. High AFP levels suggest yolk sac differentiation and also indicates aggressive behavior and poor prognosis. So elevated AFP levels in epithelial ovarian cancer can lead to misdiagnosis, particularly in young men, as high AFP levels are uncommon in epithelial ovarian cancers. So germ cell tumors of ovary and testes are associated with high alpha-fetoprotein levels. Then lactic LDH, it's an enzyme involved in glycolysis that converts pyruvate to lactic acid, and it is a significant marker for germ cell tumor, especially dysgerminomas. High LDH levels in blood can also be seen in epithelial ovarian cancer patients, and high levels have increased with higher stages of epithelial ovarian cancer with a sensitivity of 60%, specificity of 86, positive predictive value of 70, and negative predictive value of 75% when we use the cutoff level as 450 international units per ml. Now, all these tumor markers which I have talked about, they can be elevated in many other conditions, like beta HCG may be elevated in pregnancy, choriocarcinoma, CA125 in ovarian cysts, menstruation, appendicitis, CEA in mucinous tumors, GI malignancies, tobacco use, inflammatory bowel disease, HE4 in breast cancer, colonic mucosa, endometrioid ovarian cancers, inhibin in mucinous tumors, thecomas and breast tumors, and LDH in liver disease, muscle damage, and dysgerminomas. So, in addition to ovarian cancers, they may be elevated in number of inflammatory and other tumors as well. Now, coming to the new or emerging tumor markers which can be detected in liquid biopsy. These are microRNAs, DNA methylation markers, and circulating tumor cells. They are detected in liquid biopsy. What is liquid biopsy? Blood or body fluid can be taken out to look for these markers. So liquid biopsy is what is the future, and in liquid biopsy, all these markers can be detected. So you can take a blood sample and look for microRNAs in the blood sample by using various highly sophisticated molecular techniques. So microRNAs are one of the new emerging markers. They are short non-coding RNAs that regulate gene expression, and these RNAs are detected in blood and urine by molecular methods, and thus they are a part of liquid biopsy. They are non-invasive methods which can be detected by molecular methods like PCR and NGS. Now, microRNAs are dysregulated in most of the cancers, including ovarian cancer. So, one of the microRNA called LET7 and microRNA 200 families are implicated in development of ovarian cancer, whereas many other microRNAs are associated with prognosis and treatment response in ovarian cancers. So these microRNAs like LET7 can help in early diagnosis. Then in therapeutic potential, LET7 can help in selecting chemotherapy regimes. Then it has a prognostic marker and also predicts chemoresistance and disease progression. Then circulating tumor, then next new...
I'm sorry to interrupt you. Your time is up.
Okay, I'll just quickly say the next important tumor marker is circulating tumor cells. These are the tumor cells that have detached from the primary tumor. Again, they can be detected in blood and body fluids by the molecular methods, and circulating tumor DNA can also be detected. And last is a number of potentially emerging new biomarkers are copper isotopes, which can be detected in the serum for early diagnosis. And one more, which I would like to point out, is folate receptor alpha, which can be seen in the blood and in the tissue samples by molecular methods, again for progression, tumor progression, and cancer therapy. So this is about the various biomarkers, and a number of NGS panels are available where in the tissue, formalin fixed tissue, we can look for a number of important genes that are implicated in ovarian cancer, like BRCA1 gene, BRCA2, ERID1, and CDKN2A, and numerous other genes. So these are my references, and thank you.
Thank you so much, Dr. Charanjit, for that excellent talk on covering all the basics of the biomarkers and as well as the emerging biomarkers. These are the basic tests we do in any patient with an adnexal mass. So thank you so much for explaining all that. So we go on to the next topic. So Nilanjali, if you can introduce the next speaker, please. Okay, so Dr. Charanjit, if you can stop your screen share.
Yeah, I just stop. Yeah, stop share.
Yeah, please show the CV slide of Dr. Neha. So imaging is something, it's a basic investigation we all need to do in a case of an adnexal mass. So, how do we decide which to do and what are the things that we need to look at in the imaging is what Neha is going to tell us about. She's a professor in radio diagnosis at VMMC and Safdarjung Hospital, has a lot of publications and has done various presentations in international, national, and state level conferences. And her special interest is on women's imaging and abdominal imaging. So over to you, Neha.
For the kind introduction. And thank you so much for this opportunity on this platform. So I'll be discussing about imaging approach to characterize the adnexal masses. I hope my slides are visible.
Yes,
Yes.
we can see.
Okay. So, adnexal masses are often detected incidentally, and ovarian carcinoma is the second most common gynecological malignancy and fifth leading cause of cancer death in females. And it is very essential to characterize them early for appropriate management. So, we'll be learning about what are the imaging modalities, what are the characteristic imaging features, and what imaging algorithm should be used. So, how to approach a mass? First of all, age, menopausal status, family history, clinical history, examination, tumor markers, which has already been covered in detail, and imaging. So, for imaging modalities, we have initially the primary modality is ultrasound, followed by MRI, CT scan, and PET CT or MRI. Coming to ultrasound, it can be transabdominal or transvaginal. So, transabdominal ultrasound is usually used in young, unmarried females or very large masses or where we want to see certain ancillary findings. Transabdominal ultrasound has high sensitivity but poor specificity, and it is an operator dependent technique. So there are certain entities where a radiologist is quite confident in their diagnosis, like a simple cyst, hemorrhagic cyst, endometrioma, dermoid, or a vascular solid component in a cyst. But certain imaging findings, they lack specificity, like internal irregular thick septations, which one of us might call irregular, but some other radiologists might call them regular septae, some solid appearing nodules without blood flow, avascular solid lesion without shadowing, and large masses. So, what's the role of Doppler? Doppler has a sensitivity of 84%, a PI of less than 1, and RI of less than 0.4 to 0.8, and a PSV of more than 16 centimeter per second, with central blood flow has to been described as features of malignancy. Usually, benign masses show peripheral pattern of vascularity. Contrast enhanced ultrasound is again an upcoming modality which plays a role. It has a high diagnostic accuracy. The enhancement is seen in reference to the myometrium, and there are certain quantitative and qualitative parameters which are evaluated on CEUS. Ultrasound elastography is a very, very latest technique which is being used. It is based on the elasticity of the mass, and as we expect, a malignant mass is harder than the benign mass, so we expect higher elastography values in a malignant mass. So this is, for example, elastography on a ovarian dermoid. You can see this bright echogenic mass in the adnexa, and this is the ROI which is placed on the mass, and we have measured the elasticity of the mass in kilopascals, which is around 46 in these cases, and the malignant masses show much higher, about 100 or 200 kilopascals. So this is again a newer modality which is being used. MRI is best for characterization, and it accurately characterizes the fat, hemorrhagic or proteinaceous contents of the mass, and it detects the enhancement within the solid component beautifully, and it is very good for local invasion. Slides are not moving. I'll just share again. Yeah. So next modality is CECT. It is not for characterization of the primary ovarian mass. It is for staging and detecting peritoneal carcinomatosis. Response is assessment after the treatment. And when we are unable to detect small volume extra ovarian less than 5 mm deposits when ascites is absent, CT, contrast and CT can help us. So basically for characterization of a ovarian mass, MRI is excellent, but when we are sure even on ultrasound that the mass is malignant, we can go ahead with CT directly for staging. CT has a sensitivity of 81% and specificity of 87% in ovarian cancer diagnosis. Coming to PET, it is to detect the primary tumor in case of metastasis. Suppose we are getting diffuse metastasis and the primary tumor is not localized. If metastatic ovarian carcinoma is suspected, then we can use PET to detect the site, the primary site of malignancy. It can also be used to evaluate the response. What are the pitfalls? Certain benign masses like teratoma and endometriomas may also show uptake. Then small, less than 1 centimeter necrotic and low-grade tumors may not show uptake. So this is the algorithm. When we suspect adnexal mass, we do a transabdominal or transvaginal ultrasound. If we suspect benign on ultrasound, no further treatment or follow-up. If we suspect malignant, then we can go for CT directly for staging. If the mass is indeterminate, then we go for MRI for primary characterization of the mass. If on MRI it appears to be benign, follow-up, and if malignant, then CT for proper staging followed by the treatment. So what is the role of imaging? It is the detection of the mass, determine the origin of the mass, characterize it, stage it, and suggest appropriate management. So laterality of ovarian masses is a big hint to the diagnosis, whether the mass is unilateral or bilateral. So certain entities are more commonly seen bilaterally, for example, endometriosis, serous cyst adenoma or serous cyst adenocarcinoma and Krukenberg's tumor. According to morphology of the mass, they can be characterized as unilocular cystic mass, multilocular cystic mass, mixed solid cystic mass, or solid mass. So we'll approach in this fashion, coming to unilocular cystic mass. So what are the differential diagnoses of a unilocular cystic mass? It can be a functional cyst, hemorrhagic cyst, endometriotic cyst, serous cyst adenoma, or non-ovarian para-ovarian cysts. So this is the ultrasound picture of a simple cyst, a fluid containing avascular structure with posterior acoustic enhancement, no solid component. On MRI, it will be simply hypo on T1 and hyper on T2 weighted sequences. So coming to description of solid tissue, when do we say a tissue is solid on ultrasound? When it is echogenic, when it appears as a mural nodule or a papillary projection of more than 3 mm in size, when it shows color uptake or it shows enhancement on CT or MRI. When do we say it is not solid? When the component is avascular, hyperechoic structure, like in this case, this is a dermoid cyst, but the component is avascular. Then it can be a blood clot or mucin. Then certain septae can be avascular. Then an irregular cyst showing focal thickening, for example, in this case, this area, but this is less than 3 mm in height. So this is not considered as a solid component. Coming to functional cysts, normal follicles are usually less than 20 mm in size, dominant follicles 20 to 25 mm, then follicular cysts and corpus luteum cysts. In all these entities, they usually show complete resolution on follow-up scans. So this is a picture of a dominant follicle, a simple follicle with simple bright signal on T2 weighted images, and this is a picture of a corpus luteal cyst showing peripheral vascularity or ring of fire pattern. Hemorrhagic cysts usually show this appearance of a retractile clot or a reticular meshwork pattern on ultrasound. Endometriosis. Classical picture on ultrasound is homogeneous fluid level echoes or fluid level in certain cases. And on MRI, T1 fat set sequence is the key sequence which will show the lesion is appearing bright because it is not fat. It will not suppress on a fat set sequence. It will appear bright as in this case. So this is a classical endometrioma. So a typical endometrioma, a unilocular cyst with thick, smooth wall and ground glass echogenicity. Sometimes you can see peripheral echogenic foci also. Atypical endometrioma, when you see a irregular, apparently solid hyperechogenic structure within this cystic lesion, as in this case, with ground glass echogenicity of rest of the cyst. Why do I call apparently solid? Because this is not a solid area. This is just a blood clot. It is not showing any increase in vascularity. It will appear like a solid. It will mimic a solid nodule. So this we have to differentiate. So serous cyst adenoma is a benign tumor. It is again a unilocular cyst with thin regular lining, no internal septation or papillary projection, no contrast enhancement. So this is how it appears on MR, a clear cystic lesion without any septae or solid nodule or enhancement. Then what are the unilocular non-ovarian cysts, that is para-ovarian cyst? In these cases, you will identify the ipsilateral ovary as in this case, and this cyst will move independent of the ovary, and usually the beak sign is not seen in these cases. Non-ovarian cyst hydrosalpinx can also be seen as a unilocular cystic lesion, and in these cases also you will see ovarian tissue draped around the dilated tube, and tube will show a retort shaped cystic structure. Peritoneal inclusion cysts are usually unilocular smooth wall cysts. They happen to be post-surgical and they have characteristic insinuating margin within the pelvis. They do not have any well-defined shapes. As in this case, they try to insinuate along the facial planes and they are clear cystic lesions. Coming to multilocular cystic masses. Differentials are endometriotic cyst, tubo-ovarian abscesses, and mucinous cyst adenoma. So, endometriotic cyst can appear as a multilocular lesion, as in this case, you are seeing this area with homogeneous echos, but there are multiple locules with dense areas also, and these on MR appear quite dark on T2. This is because of blood content within these locules, and rest of the lesions appear quite hyper intense. So it can appear as a multilocular cystic lesion with variable echogenicity. Then tubo-ovarian abscesses, then they can also appear as multilocular cystic lesion with variable echogenicity, thick wall, increased color flow. So this is the typical appearance of an inflammatory mass lesion. And on MR, these will show slightly hyper-intense wall on T1 weighted, and which will show diffusion restriction. As you can see in this case, the internal area is pus. So it will show diffusion restriction and enhancement on post-contrast. Mucinous cyst adenoma, these are usually benign multilocular cystic lesion, thin regular wall, thin septae, a stained glass pattern. This is because of mucin, the variable echogenicity, and they can also present with pseudomyxoma peritonei. So this is a classical mucinous cyst adenoma, multiloculated, thin, smooth septae, and you can see very minimal enhancement on the post-contrast scan. Mixed solid cystic masses. These can be epithelial tumors, endometrioid carcinoma, clear cell carcinoma, germ cell tumor, granulosa cell tumor, Sertoli Leydig cell tumor. So the basic difference between serous cyst adenocarcinoma and mucinous on imaging. Serous cyst adenocarcinoma are usually bilateral, small, irregular with presence of papillary projection, mural nodule, solid component, thick septae and vascularized. Whereas mucinous cyst adenocarcinoma are usually unilateral, large, smooth with number of locules showing variable echogenicity, that is the honeycomb appearance, and they usually present with pseudomyxoma peritonei, and serous carcinomas usually present with peritoneal carcinomatosis. So this is a case. You can see adnexal mass which is showing a complex solid cystic pattern. There are multiple locules of variable echogenicity. This locule is appearing anechoic, this one is appearing pseudo-solid, and there are certain areas which are showing vascularity. MRI of the same case, you can see multiple locules. This area is showing relatively hypointense, this is hyperintense, and there is variable signal intensity. And on diffusion, this area is showing the diffusion restriction. So this is the solid area. So this is the classical picture of mucinous cyst adenocarcinoma. Another case, a large mass, unilateral, multiple locules, variable signal intensity, mucinous cyst adenocarcinoma. Another case here, you can see a right adnexal mass, which is relatively small, solid component is more. It is a complex solid cystic mass. Another left adnexal mass, similar picture. So bilateral, small, solid, complex solid cystic masses. And MRI again shows the same picture, bilateral, complex solid cystic masses. These are serous cyst adenocarcinoma. So endometrioid and clear cell carcinoma, they are associated with endometriosis. So when do we suspect changes of malignancy in an endometrioma? When there is rapid growth, multilocularity, presence of mural nodules, disappearance of the classical T2 shading, and enhancement. As in this case, you can see in this left adnexal mass, there are certain areas, certain mural nodules which are showing enhancement, and here again there is a solid area which is showing enhancement. Another case, this was a follow-up patient of endometrioma, which gradually developed malignancy, and you can see solid area, which is showing vascularity, very thick septae. And MRI of this patient, you can see this mass, which is showing solid areas, and these solid areas are showing enhancement in the post-contrast images. And on the left side, there is still blood component seen in this lesion. So this is endometrioma with malignant change. And as said, it can present with endometrioid carcinoma, and in this case, CA endometrium along with adnexal mass, and this was endometrioid carcinoma. Dermoid cyst usually shows fat fluid interface. Presence of fat is classical for dermoid cyst, Rokitansky nodules, teeth, floating debris. Then on MRI, these will present as complex masses with cystic and solid areas with fat. Presence of fat is hallmark for dermoid cyst. So as in this case, you see this echogenic area, large bright area with acoustic shadowing, hyper echogenic line and dot appearance. And in this case, this floating nodules, you can see floating spherical structure. These are all fat lobules. So presence of fat is classical. Again, in this case, these bright areas within this lesion on ultrasound is fat. On an MRI, this is T1 in which these are appearing bright. These lobules all are fat. So this is a classical sack of marble sign seen in a dermoid. Again, the same picture of a dermoid, you can see the bright areas on T1 weighted images which are being suppressed on fat set sequences. So this is a classical mature teratoma. So what are the signs of malignant transformation of mature cystic teratoma? Large heterogeneous solid enhancing tissue, irregular calcification, small scattered foci of fat, cystic components containing simple fluid rather than fat. So these are signs of malignant transformation of a mature
Ma'am,
cystic.
your time is up.
15 minutes up?
Yeah.
Okay, I'll wind up. So these are the signs of malignant transformation of mature cystic teratoma. So similarly, in yolk sac tumor, the tumor markers have already been discussed, raised alpha fetoprotein and a bright dot sign. A very bright vascular structure within a tumor is usually indicative of yolk sac tumor. So coming to solid masses, these are commonly fibrothecoma, fibroma, dysgerminoma, and Sertoli lytic cell tumor and Krukenberg tumor. So I'll cover the common ones like fibromas are usually solid tumors, and when they present with ascites, it is known as mixed syndrome. And these are large solid masses and they can mimic pedunculated fibroid in certain cases. Granulosa cell tumors can give an appearance of solid, Swiss cheese appearance, solid cystic with areas of hemorrhage and raised inhibin levels. As in this case, this is a 18-year-old female with a complex solid cystic mass, raised inhibin levels, and it came out to be a granulosa cell tumor. Sertoli lytic cell tumor have hormonal effects with increased androgenic effect on the patient, and they can appear as predominantly solid masses with marked enhancement. Then dysgerminoma has the classical solid appearance with fibrovascular septae in a young patient, a predominantly solid mass, as in this case, a 24-year-old female with a large solid mass with fibrovascular septae, classical dysgerminoma, raised LDH levels. Then rarely with raised beta HCG level, this was a case of primary ovarian choriocarcinoma. So these can appear as predominantly solid with certain cystic areas. Krukenberg tumors, the classical picture is bilateral adnexal homogeneous solid masses. So lymphomas are rare masses. They are also appearing as bilateral homogeneous solid masses. So I'll skip this part. Just a brief note on benign features of aorta. These are B features, a unilocular cyst, solid component less than 7 mm, causing acoustic shadowing, smooth multilocular tumor less than 10 centimeter, no color flow. These are very specific benign features. And malignant features, irregular solid tumor, presence of ascites, at least 4 papillary structures, irregular multilocular solid tumor with largest diameter more than 10 centimeter, and very strong blood flow. These are M features. So based on these features, we can differentiate whether the mass is benign or malignant. And when the mass falls in an indeterminate category, we can go for MRI to characterize the mass. And this is the ORADs, according to which the possibility of malignancy increases from ORADs 1 to 5. And I'll just cover the higher risk, like for example, ORADs 4 lesions. When it is a multilocular cyst larger than 10 centimeter with higher color score with irregular septae, these lesions fall in the category of ORADs 4. And when there is a multilocular cyst with definite solid component color score of 3 to 4, then it is definitely ORADs 5. So this is how the color score is done, which is very subjective on ultrasound. And I had certain questions. Can we put up them now, or because of shortage of time, we can skip them?
I think we can, maybe at the end, we can do it if there is time.
Okay, ma'am. Okay.
Okay, okay.
Yeah, I'll just stop sharing.
Thank you so much, Neha, for that excellent, and lucidly explaining all the different types of head neck cell mass and how to differentiate and how to select, which is the imaging modality to use. Thank you so much once again.
Okay.
So we go over to session 2. Nilanjali,
Yes, ma'am. So we
please
can move
introduce
on to the next
chairpersons.
session. Yes, ma'am. We can move on to the next session. So can I have the slides of the next session, please, the chairpersons? Can I have the slide of first chairperson, please?
Dr. Vidya Thobi.
Dr. Vidya Thobi, can I have a slide, please?
Yeah, we'll just I can just introduce Dr. Vidya. Dr. Vidya is a dear friend. She's the vice president elect. Yeah, okay.
Yeah.
So Nilanjali, you can.
Yes, ma'am. So Dr. Vidya Thobi, Madam is President, KSOGA 2023, Chairperson, Food, Drug and Medical Surgical Equipment Committee of FOXY 2018 to 2020. Best Committee FOXY Award. Madam is received multiple awards, FOXY Champion Awards, National Corresponding Editor of JOGI. And Madam has multiple other awards and accolades to her credits. Can I have the next slide, please? Dr. Rashmi Kahar, Madam has expressed her inability to join the meeting. Can I have the next slide, please? Can I have the next slide, please?
Dr. Archana Basir.
Dr. Archana Basir, Madam is Consultant Obstetrician and Gynecologist and Director at Akash Hospital, Indore. Madam has been Vice President FOXY of 2020, Organizing Secretary ICOG 2021, and she has held various very important positions in FOXY, ISAR, IAGE. She has been Chairperson FOXY Imaging Science Committee 2015 to 2017. We welcome you, Madam. So now I hand over to the respected chairpersons to take over the session. Madam Vidya Thobi has joined. Madam, kindly introduce the speakers.
Dr. Vidya?
Yeah. Hello.
Yes, Dr. Vidya.
Yeah. So thank you very much. I think I must congratulate Dr. Sarita. She has such a wonderfully designed this program, and I think it is very, very informative program. And I'm very happy to introduce you a very prominent speaker of today's, that is Dr. Sabuhi Qureshi, who is Professor, Head of the Department of Oncology, Dean Kalyan Singh Super Specialty Cancer Hospital Institute, Lucknow. She is a IGCS Traveling Fellow, Segal Cancer Center, Montreal, Canada. And she is a certified colposcopist. She has got more than 50 publications, and she is a secretary of UPAGOI. So we are going to learn from her something about the planning of the surgery and how to go ahead. So let us listen to the learned speaker, Dr. Subuni. Over to her. Thank you.
A very good evening to all the respected chairpersons. And at the outset, I would like to thank Dr. Sarita for giving me an opportunity to be part of this program. Really an excellent way of passing on the knowledge, sharing the knowledge, and capacity building of people who are around us, because only together we can join hands to beat cancer. So I hope my slides are visible.
Yes, ma'am.
So I bring greetings from my institute. This is our institute, the map of Kalyan Singh Cancer Institute. The learning objectives from this today's talk is we would know something about the covariant cancer statistics and how to identify malignant masses, when to refer to a gynae oncologist, and to decide the primary debulking versus interval debulking surgery. My work has been made easy by the previous talks by Dr. Bindia, and a very good talk on imaging and tumor markers also by Dr. Ahluwalia. So now, as we know, when we move ahead, that ovarian cancer is the second most common gynecological malignancy in resource-rich countries, and the third most common gynecological malignancy in resource-limited countries. And it is third common after cervical and uterine cancers in our country too. And in 2022, the estimated new cases were about 3 lakh, and the deaths were 2 lakhs. So as we can understand, the mortality is high in ovarian cancer as compared to other gynecological malignancies. So 95% of the ovarian malignancies are epithelial, and the remainder of them come from the other cell types, that is germ cell tumors or 6-coat stromal tumors. The overall incidence of the epithelial tumor, it varies from 9 to 17 per 100,000, and it is highest in the high-income countries, with the exception of Japan. And this incidence rate increases proportionately with age. The largest number of patients with epithelial ovarian cancer is found in the 60 to 64 years of age group, and the median age is about a decade earlier in the low-income countries. So usually the women, they present with bloating, abdominal distension, urgency, frequency, difficulty eating, nausea, anorexia, early satiety, pelvic or abdominal pain, dull aching, more common, and acute can also happen because of intestinal obstruction. Sometimes they can present with that. They can present with vaginal bleeding, hirsutism, specifically in those cancers which are producing hormone functional tumors. And there could be acute presentations also, like dyspnea because of pleural effusion. Rare presentations could be there because of venous thromboembolism, lymphadenopathy, paraneoplastic syndromes could be there. And sometimes they are diagnosed incidentally when the examination or imaging is being done for other disease. So very important when we want to diagnose when a lady comes to us with an adnexal mass, a detailed medical history has to be taken to a certain possible risk factors, including history of other cancers and history of cancer in the family. And followed by this, a complete physical examination is a must, which would include a general examination, breast examination, abdomen, pelvic, and rectal examination. All must be performed to come to a conclusion. So when we talk of malignancy, when the mass is there and we want to decide whether it is a malignant mass or not, the presence of malignancy, the features are that the age of the patient usually, for germ cell only we have young patients coming to us, but older for the epithelial malignancies. If the tumor is bilateral, if the tumor is fixed clinically, if there is ascites, if there is ultrasound shows complex masses with solid areas, and in CT and MRI we find metastatic nodules and the elevated tumor markers. They all are referring to the presence of malignancy. So the important point now is to diagnose the mass which is there. So diagnostic evaluation, whenever we are doing, is done with the aim of establishing a diagnosis, to know the extent of the disease, to rule out metastatic disease from other malignancy, that is, to rule out to know whether it is a primary malignancy or it is a secondary malignancy, it is a Krukenberg tumor. And then to select patients for primary debulking or for NACT, followed by interval debulking surgery, and referring the patient to a gynae oncologist. So which patients would benefit from referral to a gynae oncologist? This is from RCOG and ACOG, both 2016, they recommended that women with elevated tumor markers, CA125 level, AFP, LDH, HCG, if they are high, the ultrasound findings are suggestive of malignancy, ascites, or a nodular or a fixed mass is there clinically, and evidence of abdominal or distant metastasis is there, or the premenopausal woman with an elevated score on a formal risk assessment test like RMI is more than 200, the ROMA is high, ORADS is 4 to 5, Adnex iota is LR, then obviously such patients should go to a gynecologist. Management, as we know, for an ovarian cancer, the important thing is they have to be managed. The surgical staging has to be done. Only thing is that we need to decide whether it is a primary surgery or we need to do a primary debulking or a secondary debulking surgery has to be done. So surgical staging and cytoreduction followed by adjuvant chemotherapy is the management approach used for most of the patients with epithelial ovarian cancers, and optimal cytoreductive surgery with adjuvant chemotherapy increases the likelihood of long-term disease-free survival. So when we say about this, whether it is an upfront surgery or an interval debulking after NACT, we want to know that patients who can be optimally cytoreduced, that is, we are left with no microscopic disease, they would be certainly benefited by a primary debulking surgery, and patients who have extensive disease as opposed to them, which cannot be removed completely, should be offered interval debulking followed by NACT. And we have talks after this, so I'm not detailed on this, but we have enough literature, we have meta-analysis and RCTs are available, which tells us that the overall survival for patients who undergo primary debulking surgery is comparable to those who undergo interval debulking after NACT. So how to decide whether you go in for a primary debulking or an interval debulking? So the important thing is that we do a clinical examination, and the imaging will help us to decide, take a make a diagnosis, and then we need to see whether the disease is limited to the pelvis or not. If it is limited to the pelvis, that is, it is a stage 1 or 2 disease limited to the ovary or to the pelvic peritoneum, then a primary debulking surgery is chosen as a primary modality, followed by adjuvant therapy. But for those who have extensive stage 3 or 4 disease, for such patients, NACT followed by interval debulking surgery is chosen. In selected patients with cytologically proven stage 3C and 4 disease who may not be good surgical candidates, also, and such patients should get 3 to 4 cycles of neoadjuvant chemotherapy, followed by interval debulking surgery and additional chemotherapy as demonstrated in the EROTC and CHORUS trials. So we have enough evidence available, and it is specifically said that NACT is particularly useful in patients not only with those who have advanced disease, but also with those who have poor performance status, who cannot be taken up for surgery immediately because they have significant medical comorbidities, or they have visceral metastasis, who have large pleural effusions and are gross ascites, should receive NACT followed by interval debulking surgery. And for as far as the visceral metastasis is concerned, most experts, they agree that the patients with any of the following criteria, they have an unresectable disease, like when they have a diffuse and or deep infiltration of the small bowel mesentery, diffuse carcinomatosis involving the stomach and or large parts of small or large bowel, infiltration of the duodenum and or parts of pancreas, not limited to the pancreatic tail, involvement of the large vessels of the hepatoduodenal ligament, celiac trunk, or behind the porta hepatis, involvement of the liver parenchyma, lung metastasis, lymph node metastasis, and axilla or mediastinum. So these are the points which are taken as unresectable disease, and such patients should not undergo primary debulking surgery. Then there is also a role of diagnostic laparoscopy here. I would like to elaborate a little about this also, that it is often difficult in some patients to preoperatively assess by imaging and the clinical history and examination whether women with advanced EOC can be optimally cytoreduced at the time of primary surgery or not. Therefore, for these women, women who are stage 3 or 4 EOC in whom it is not clear if complete cytoreduction is possible or not, diagnostic laparoscopy is done to visually assess for resectability, and if the surgeon conducting the assessment feels disease is resectable, primary surgery is, they go ahead with primary surgery. Otherwise, the patient is taken up for a NACT after taking a biopsy. So in this only, there is a Fagoty score. I mean, there are objective scoring systems available. There is PCI, peritoneal carcinomatosis index is there, and the Fagoty score, in which the presence of a mental cake, peritoneal carcinosis, diaphragmatic carcinosis, mesenteric retraction, bowel and or stomach infiltration, and liver metastasis stratified the basic inclusion criteria and were assigned a final predictive index value of 2. And in the final model, a predictive index score of equal to more than 8 identified patients undergoing suboptimal surgery with a specificity of 100%. And the positive predictive value was 100% and the negative predictive value was 70%. So this is the table just to show the various points. If it is not present by a particular point, it is given a score of 0. Otherwise, it is given a score of 2 if it is present. And more the number of involvement, more the sites, higher the score, higher is the chance that the patient is not a good candidate for primary debulking surgery. So a word about the NACT. What happens is that when we are talking women with a high perioperative risk profile or a low likelihood of achieving cytoreduction to less than 1 centimeter of residual disease, ideally to no visible disease, should receive neoadjuvant therapy. And this is the guideline from Society of Gynec Oncology and American Society of Clinical Oncology. So we have enough evidence available, and all of them, they suggest that before neoadjuvant therapy is delivered, all patients should have confirmation of an invasive ovarian fallopian tube or a peritoneal cancer. That is a must. The chemotherapy cannot be started without a biopsy report. So all those patients who have less likelihood of getting optimal cytoreduction should undergo a neoadjuvant chemotherapy. So when we come to surgery, the details would be taken on later into the lecture. What I want to emphasize here is whether it is PDS or IDS, the aim is to get no residual disease, that is R0, or less than 1 centimeter of residual disease. And it would be, this is the process of staging which is done where we take peritoneal washings, careful inspection and palpation of all peritoneal surfaces, biopsy of all suspicious lesions, infracolecomectomy, biopsy or resection of any adhesions, random biopsy of normal peritoneum of bladder reflection, cul-de-sac, right and left paracolic gutters, both pelvic side walls in the absence of obvious plants, selected lymphadenectomy of pelvic and para-aortic nodes, and total extrafacial hysterectomy, bilateral salpingo-oophorectomy. So this is to summarize the whatever I have shared in the lecture, that the first thing and the foremost thing is to obtain a CT chest, abdomen, and a pelvis, and to assess the stage of the disease, the extent of the disease. If the disease is limited to the pelvis, that either it is a stage 1, it is limited to the ovary, or a stage 2 disease, that is it is limited to the pelvis, then we go in for primary cytoreductions. Primary cytoreductive surgery, and most patients will receive 6 cycles of adjuvant platinum or taxane chemotherapy after this. If suppose the patient has a stage 3 or a 4 disease, that means she has an advanced ovarian cancer, then the patient can have a diagnostic laparoscopy to assess the resectability if it is not obvious on imaging. And if it is so, then the patient would, if the disease is not resectable on laparoscopy, then the patient would have NACT of 3 cycles, 2 to 3 cycles, and we repeat CT scans after that to assess the disease resectability. And if the disease has responded to the treatment, then the patient undergoes cytoreduction and followed by 3 cycles of adjuvant platinum taxane chemotherapy. If suppose the disease is still not resectable, disease is advanced or is static on chemotherapy, then probably she's a platinum resistant disease and she would require alternatively either a single agent chemotherapy or alternatively another 3 cycles of platinum taxane chemotherapy may be administered and the resectability can be reassessed. So this is this is to summarize the whole thing about the approach to the ovarian cancer management. Thank you so much for your kind attention. Thank you.
Thank you. It was, I think, complete talk. You have covered almost all the hello.
Yes, we cannot hear you, ma'am.
Yeah. Thank you very much. Thank you. That's what I wanted to say, that you have covered almost all the everything in this topic. And there is only one question. Excellent talk it was. Just one question was that may not related. I think that was for the previous speaker. But they have asked about what about the ORADs on USG description. So If
Yeah,
you can
ORATs,
highlight for
Neha
us,
already
ORATs. Already it was covered in the previous talk.
elaborated. Yes,
Yeah,
yes.
it was talk. So I think thank you very much for this excellent talk. Let us move for the next topic. And I request my co-chairperson to introduce the next speaker. And if any questions are there, this is for the audience. Please put up in the chat box. Thank you. Two more. Yeah. Thank you very much.
Is Dr. Archana Paser here?
I'm not. I will just see whether she's there in the audience.
Madam is not present.
Madam has not
Okay.
joined us. So I'll introduce her also.
Yes, please. Yeah.
Yeah. So Dr. Shweta Tehlan is a consultant gynae oncologist and robotic surgeon, Fortis Hospital, Mohali. Her interests are minimal access surgeries in gynec cancers, cytoreductive surgeries, fertility preservation in gynec cancers, and she's a member of many societies and many organizations like AGOI, ISSCP, ESGO, AGRS, and SPSOI. She has got several publications, several papers and chapters in various national and international journals. So over to Dr. Shweta for her topic. Thank you very much.
Good evening, ma'am. Thank you for the
Share
kind
your,
introduction.
you can share your.
So first of all, I would like to thank Dr. Sarita for this opportunity. I'm just trying to share my screen. Just give me 1 second. Is it visible now?
Yes, ma'am.
Yes. Yes, thank you.
It is
So
visible.
today I'll be speaking on surgery for early ovarian cancer.
Yeah.
Just briefly, we all know the staging of ovarian cancer. So these are the important points that I've highlighted in red. So stage 1 changes from A, B, and C depending on the peritoneal washings, the tumor on ovarian surface, as we all know. And stage 2 includes something called as pelvic intraperitoneal tissue. So if there are implants on the pelvic peritoneum or fallopian tubes involved, it becomes a stage 2. Hello?
Yes.
Yeah. And similarly, in stage 3, we have the involvement of RP nodes, including the pelvic and paraaortic node. If they're cytologically or biopsy positive, it becomes stage 3. And also the the peritoneum above the pelvic brim, including the omentum. It becomes a stage 3 disease. Similarly, in stage 3C, you might see that extension of tumor to the capsule of liver becomes a stage 3 disease. Why I'm saying all this is because ovarian cancer is a cancer which is staged surgically. So whatever you remove during surgery, whatever tissues you are taking out of the patient's body and sending for a histopathological examination, this will determine the stage of the patient. So no imaging, no diagnostic laparoscopy only can tell you what stage it is. So ovarian masses which are suspicious for harboring cancer, as has been described in the previous video, the talks, should be taken up for an appropriate staging procedure via laparotomy. And complete evaluation of the abdomen and pelvis should be done, and tissues should be taken as per protocol for a detailed histopathological examination. Only then we can correctly say that this is the stage of the patient. Thorough and complete surgical staging, why it is important? Because one, it is very important for our treatment planning. We know that as the stage changes from 1A to 1C to 2 and then to stage 4, the treatment changes in terms of adjuvant therapy, adjuvant targeted therapies like bevacizumab and so forth. And also the prognosis changes because we know that as the stage increases, the prognosis goes down. So, for a good surgery for ovarian cancer, remember that you have to see everything that is in the abdomen by your eyes and by your hands. So, it is what the surgeon does not see that kills the patient. And that's why open surgery or extraoral laparotomy is still the gold standard for all suspicious ovarian masses that you think might come as cancerous in the final histopathology. Why we don't want to go for a minimal access surgery in suspicious masses is, one, if you rupture the ovarian mass while handling it, it upstages the disease. And incomplete evaluation of the disease is very crucial thing. Even in with experienced surgeons, there are some areas that are always better done with an open surgery, like running the whole small bowel, the whole small bowel mesentery, areas like posterior diaphragm, porta hepatis, lesser sac. So these are always better evaluated and cleared from tumor with an open surgery. Also, you always risk the port size metastasis. So masses such as these solid cystic angry looking masses should be taken out intact, and a complete surgery done should be the plan. So as has been described by the previous talk very detailed and very elaborately and nicely, that when you plan for a surgery, you should do a good quality contrast enhanced CT scan with both oral and IV contrast. Only then you are able to assess where the disease is, how much you have to operate on the patient, and so forth. If you are planning for a fertility preserving surgery, or if you think the pelvis is not clearly seen on a CT scan, you might go in for an MRI of the pelvis. Diagnostic laparoscopy, as madam has told, may be required in some patient, whether to decide whether to go ahead with the laparotomy or not. And frozen section always. So whenever a patient who is having suspicious mass, you're taking for a surgery, frozen section is a must, because a lot of decisions as to if the frozen section comes positive for, say, invasive cancer or borderline or benign, how much surgery are you going to do, how much omentum lymph nodes you're going to remove or not. So frozen section is a must when you're taking a suspicious ovarian mass. Now coming to the steps, it's a midline vertical incision. Never go for a funnel steel incision, because if the frozen comes positive, then it becomes a tricky situation, because upper abdomen cannot be assessed well with a funnel steel incision. So midline vertical incision is the standard. First step, you take the ascitic fluid for cytology, or if there is no ascites, then you wash the peritoneum with saline and take those washings for cytology. Then you visually assess and palpate the whole abdomen, all the abdominal surfaces, the surface of small bowel, mesentery, serosa, liver, spleen, capsule, as has been written in the FIGO staging also, gallbladder, appendix, everything has to be assessed. Then take biopsies from the abnormal areas, or if there are deposits, remove those peritoneum. Or if there are no deposits on the peritoneum, you have to take random peritoneal biopsies from the normal looking surfaces, from the pelvic peritoneum, from paracolic gutters, diaphragmatic peritoneum, and like that. Then we come to the salpingo-oophorectomy and hysterectomy. If it's a young patient, we can plan for a fertility preserving surgery also, where we will avoid removing uterus and the normal looking ovary. Then omentectomy, infracolic versus supracolic. If there are deposits in the infracolic omentum, then definitely the complete omentectomy with supracolic till spleen has to be done. If there are no deposits in the omentum per se, it's a very early stage 1 disease, you might get away with the infracolic omentectomy. And then pelvic and para-aortic lymph node dissection in early stage tumors, because if nodes are positive, it's a stage 3 disease. Now, this is a position of patient that I use for an exploratory laparotomy. The hands are outside and given to the anesthetist for managing IV fluids and blood transfusion and so forth is required. My second assistant is standing between the legs, which gives a very good assistance. And when you're doing upper abdomen, you can stand in between the legs and do it. I operate from the left side of the patient while doing pelvis, and right side when doing the upper abdomen. Now coming to the video itself. So like this, we have marked the pubic symphysis, xiphisternum, the lower margins on the ribs. And now we give a midline vertical incision. So this is just previous scar that is being removed. And always go slowly. If it's a previous surgery, like previous cesarean, sometimes we have in previous laparotomies, go above the umbilicus, go above the previous scar and go to the virgin area so that no adhesions are found. So like this, slowly and slowly you open the abdomen, sheath, peritoneum. And then once you have opened, you have entered the abdomen, you're inside the peritoneal cavity, you might have to increase the incision. Like here, I'm increasing the incision to xiphisternum because upper abdomen cannot be assessed with a small incision. Now, first thing is taking cytology. I have taken cytology of the ascitic fluid or the peritoneal washings. And now we'll explore bit by bit pelvis, right side, left side, middle pelvis, paracolic gutters, visually and by palpation. Like this, we have to go up to the diaphragm. So here I'm just doing with palpation, but after that we'll apply retractors and see visually also. See the omentum, where the deposits are the deposits involving any part of colon or not. Run the complete small bowel. So see here I can see small deposits on the mesentery which were not seen in a very small look. So run the whole bowel, see if there are any deposits on the serosa, on the mesentery, because they have to be removed. And like that, now this is the stomach, this is the upper abdomen supracolic omentum. We are seeing whether there are deposits or not. Put a retractor near on the upper abdomen, go up to the spleen. We are going now up to the left. This is the deposit. So now both the diaphragms have to be seen. So put a retractor. Initially we saw by palpation no deposits, but now we have put the retractor, mobilized the falciform ligament, and now we are trying to see the diaphragm, and now we can see there are small deposits. So that is a problem only with palpation. If you leave the diaphragm, very small miliary deposits can be missed, like here on the right diaphragm, there are small deposits and fused with the liver. So that's why both palpation and visual examination is very important. This is the gallbladder area. And now if we want to assess the lesser sac, the lesser omentum and the porta hepatis area, we will have to mobilize a little bit of liver and open the lesser omentum to see, which we'll just see in some time. So this is the diaphragm above the liver. If there are grossly no deposits, then you can avoid this extensive surgery. So now these are the deposits on the hepatorenal surface. This is below the gallbladder, and this is on the gallbladder serosa and near the porta hepatis area. Now we'll open the lesser sac. And once we go up above the stomach, opening the lesser sac, only then we can enter the porta area. So now like this, going behind the gallbladder and in the lesser sac, we can assess the porta hepatis completely. Otherwise, our porta hepatis deposits are the area which is easily missed because they're lying behind the stomach area. So this is the pancreas that we can see. We don't have to irritate the pancreas too much, just for inspection. So this is how we take peritoneal biopsy. So there is a deposit here. We are removing the tumor deposit. And if the peritoneum is normal, then this way only you can take the peritoneal deposit. Just give a small incision on the peritoneum around the deposit. Or if no deposit, then just take random peritoneal biopsies like this. Only remove the peritoneum, leave the fat behind. Now we are coming to the pelvic part. This is the round ligament. So round ligament we have mobilized. We have taken the uterus in our hands. Now we'll go to the IP. Always open the retroperitoneum, the posterior leaf of broad ligament. Identify the ureter and then clamp the IP ligament, because sometimes because of disease, the ureter can be very close to the IP ligament. So now this is the ureter which is going down, and IP ligament now we will cut and then ligate, and then with the uterus we can mobilize it. So our hysterectomy is standard. We don't have to do a type 3 type in usually in ovarian cancer. This is me opening the UV fold, and we'll separate the bladder down. So like this, by standard hysterectomy steps we can follow if there is no obvious disease in the parametrium. So a type 1 radical hysterectomy is enough for ovarian cancers mostly. So now the bladder has been pushed down, and now similarly on both the sides we will take the uterine artery. Like this, we take the uterine artery. You know the steps of the hysterectomy, and then we will clamp, cut and ligate it, the uterine artery, and we'll complete the hysterectomy. If there is disease on the bladder peritoneum, then we have to remove the bladder peritoneum as well. If there is disease on the pelvic peritoneum, then we can take the pelvic peritoneum separately, or usually we take it with the specimen so that it is easier to manipulate when the uterus is intact, and we can mobilize the pelvic peritoneum along with the uterus and take it out. But if there is no visual disease on the pelvic peritoneum and bladder peritoneum, we are not removing the normal looking peritoneum. So this is a vaginal colpotomy. We are opening the vagina here. And this completes our hysterectomy and will close the vault. Now coming to omentectomy. So this is, we are opening the between the third and fourth layer of omentum near the large bowel, near the colon. So there is a small avascular area which is just above the colon between the third and fourth layer, after which we can enter the lesser sac. So entering the lesser sac is very important because then it gives us a detailed anatomical picture where the stomach is, where the mesocolon is, because while doing omentectomy, you have to take care that you don't have to disrupt the blood supply of the colon. The blood supply of the stomach should be kept intact. And if you stay close to colon and use your cautery with the speed, not burning the tissues too much, you can. So here you can see stomach on the upper abdomen, on the upper side. My assistant is holding that, and we are mobilizing the colon, entering the lesser sac, and then identifying the gastric arcade. So once we have identified the gastric arcade, we have to preserve the arcade. We don't want to remove the arcade because it is very important for the stomach. If the disease is involved, then only we remove that, but it's a very radical surgery. So we usually try and preserve the gastric arcade. And now like this, we have reached till the spleen. We'll apply the clamp, and this completes our supracolic omentectomy plus infracolic. So a total omentectomy has been done for this patient because there were deposits in the infracolic omentum. So once we have completed the surgery like this, the pelvis will be seen to you. It will be bare of all the pelvic peritoneum, and the vault is clear of disease. And similar, this is the ureters which are going, and the rectum has also been cleared of the all the disease. And this is the upper diaphragm. You can see that there's some stitches on the diaphragm if disease is involved. But if not involved, then we can avoid doing the diaphragm stripping. We usually do not remove the normal looking peritoneum, only deposits, then we remove it. So just briefly, like two cases I would like to present here. 20-year-old AFP of 4,000 and had a large 20 centimeter mass. So this was the mass on the CT scan, on PET scan. So like this, we know in our minds it's a germ cell tumor. She's a young patient. We should do a fertility sparing surgery. So we did an exploratory laparotomy, surgical staging, took cytology, removed that side of mass completely. Don't attempt cystectomy and morcellation of these ovarian masses. Remove the complete salpingo-oophorectomy has to be done. Then complete omentectomy, assessment of the pelvic and paraaortic nodes, and then only we came to know it's a stage 1A disease and patient can be left without chemotherapy in this germinoma. But other germ cell we have to give adjuvant. Another like 40-year-old cytology negative but a large mass. This is my last slide. I'm just coming to the end of it. So here also you can see we did the complete surgery. This is the complete pelvic peritonectomy and complete lymph node dissection. As you can see the pelvic vessels, the great iliac, external iliac vessels you can see, and you can see the lymph nodes.
Ma'am, your time is up.
Yeah, this is my last slide. So
Yeah,
this
yeah.
is how the deposits on bladder and POD peritoneum are seen. This we have removed with the mass, but if they're not enlarged, you can remove it. So just very briefly, there is something called as peritoneal carcinomatosis index. So you divide the abdominal in 13 parts, so 0 to 12, the 9 quadrants and 4 areas of the small bowel. And you always have to mention where all the deposits are present in terms of no tumor less than 5 mm, 5 mm to 5 centimeter, and tumor of more than 5 centimeter. So this is how you have to document a PCI whenever you are doing a primary cytoreductive surgery or an interval cytoreductive surgery. And once you have removed all the masses, you have to write whether you have completed the surgery or not. So this is called a CC score. So no disease, 20.25 centimeter, 2.25 to 2.5, and more than 2.5. So thank you so much. Thank you for the patient hearing and thank you for the opportunity.
Thank you, Shweta, for the very nice presentation and the video. So it's just to emphasize that if you don't find the peritoneum to be abnormal, if you don't find deposits, you don't need to remove the peritoneum. Just take out the mass and whatever is needed, the omentectomy and the lymph node sampling. Okay, so over to now we go on to the next topic, which is about cytoreductive surgery for advanced ovarian cancer. And for this, I call upon Dr. Kiran Pandey, who is the who's the president of the UP chapter of the Association of Gynae-Oncologists of India, to introduce Dr. Rama Joshi.
Thank you, Dr. Sarita. I hope I'm audible.
Yes, ma'am.
Yeah, so first of all, congratulations for a wonderful organization of this program. And it is my humble opportunity to introduce Dr. Rama Joshi. She's a well-known figure in the field of oncology, and she's principal director at HOD Gynae Oncology Robotic Surgery, Fortis Cancer Hospital, chairperson Robotic Surgeon Council for Fortis Healthcare also. She has already achieved many positions earlier also. She had been fellow of the Buffalo University, USA also, and she has been instrumental into many super specialty programs, and she's a has been president of Gynae Oncologist of India also, and very well known figure. I invite Dr. Rama Joshi for the next talk, and thank you, Dr. Sarita.
Thank you so much for the kind introduction. And I think at the outset, I would like to thank Dr. Sarita. And I really very much appreciate the way she is looking at the things and the managing it. That basically dragged me down here. So Dr. Sarita has given me this topic of the surgical cytoreduction or cytoreductive surgery for advanced ovarian cancer. I think the program had been fantastic. All the previous two lectures had been really they have done a wonderful job. And I may be having some kind of a reputation based on the principle. So we have understood now what is this ovarian cancer. The main problem of the ovarian cancer, as I just want to highlight, look at the 80% of the patients are diagnosed in advanced stage of the disease. And I think we all are facing this kind of a problem. And rather, I mean to say, we are giving a thought to it and brainstorming ourselves how these patients can be treated. This is not the scenario in India, but this is across the globe is a big challenge to manage these patients of advanced ovarian cancer. And that's how we are looking at how optimally we can manage them so that we can extend the best survival to these women, but at the same time, giving them the good quality of life as well. So whenever these patients actually we are looking at the increasing incidence of the ovarian cancer, look at in India, of course, the number of new cases are increasing year per year. And looking at the mortality rate, of course, I mean, this is the malignancy which has got the maximum mortality among all gynecological cancers. So case to fatality ratio is very high. And this is what we are all facing the challenge, how to manage them the best. And that is how Dr. Subohi has really come up with a very good outline that it's important in advanced ovarian cancer, whenever we are managing such patients, first of all, we have to understand that this is the disease. In this kind of the advanced stage of the disease, we require to have the combined treatment. And this combined treatment is going to be the surgical cytoreduction as well as the chemotherapy. We cannot skip chemotherapy, neither we can skip the surgical cytoreduction. So it's important for us to decide when to go for NACT, that is the neoadjuvant chemotherapy, and when to go for surgical cytoreduction. Why it is important and is taken as the important part of the treatment program. This is very important. That's how these patients are discussed in the tumor board, where we have our medical oncologists around, and then we jointly discuss how this patient is going to be benefited with. What is important so far as the surgical cytoreduction is concerned in the advanced stage of the disease is that we have to go for the complete resection to that of the no residual disease. Of course, we would like to go for. Of course, looking at the definition of the completeness of the cytoreduction, this varies from investigators to investigators, as well as from the institutions to institutions. Before we start with that of the surgical management, what is important is to understand how does this ovarian cancer spreads. And that is how Dr. Shweta has taken you around. That's how you're going to actually evaluate the entire peritoneal cavity, why it is so, just because of the exfoliation of the cells from the diseased ovary that actually moves within the peritoneal cavity. And wherever the disease is that we are likely, we have to pick it up. And that's how we have to evaluate. So it is the intraperitoneal spread of the disease. As it spreads, the disease also spreads. And that's how we will be looking at. I just wanted to bring up this slide to you all. What is important in ovarian cancer is what is the nature of this disease. Whether it is the high-grade serous carcinoma, whether it is low-grade serous carcinoma, or the histology is other than the serous, can be clear cell, endometrioid, or the mucinous carcinoma. It's very important for all of us to understand that each histology varies in its response to chemotherapy. So please consider, before deciding for the neoadjuvant chemotherapy, we can't just take the task to that of, in general, that any malignancy in advanced stage requires to go for NACT. It's very, very important. As I give you this example of the high grade, of course, these are most sensitive tumors. Once the histology is low grade, they do not respond to chemotherapy. And we have faced a lot of problems regarding the NACT over the period of last, say, 5 to 7 years. And we have become wiser that if the disease is advanced and it is low grade or endometrioid or clear cell carcinoma or mucinous carcinoma, these are the cases where we must consider the surgical cytoreduction, despite of it being extensive disease, and we should prefer it because they do not respond to chemotherapy. So they can progress to while on the chemotherapy. So it's very, very important aspect. What are we dealing with? So actually the true cut biopsy, ultrasound guided true cut biopsy, maybe of the omental disease, that will give us the idea what is the histology we are treating. So standard of care is definitely the surgical cytoreduction. There have been debate, and I think you have also been listening, when to go for primary or the interval surgical cytoreduction in advanced stage of the ovarian cancer. So far as defining the optimal cytoreduction, as I was mentioning, over the period of number of years, the definition of optimal surgical cytoreduction actually has varied. Less than, according to Griffith, then Hecker and Barrick, and then Hoskins and Burgett. But actually, no macroscopic disease should be taken as the standard. But still, the GOG and also, I think the Fagoti and all, they are considering as less than 1 centimeter as that of optimal status. So actually, it varies from institution to institution. And it was very, I think we became wiser once we know that it was Sugar Baker who actually introduced the assessment of the intraperitoneal spread of the disease, and was mentioned by Shweta as well. And this peritoneal carcinomatosis index is very, very important. As a part of the protocol, whenever we open, we must explore, as you have already seen, how to explore. And these are, of course, I mean to say the 9 regions, and in total, 13 regions which you have to assess. And out of these 13 regions, you will find that is the proximal jejunum, the distal jejunum, proximal ileum, and distal ileum. These are all the areas one should really be exploring at. And then accordingly, we'll be calculating the PCI. PCI basically gives us the burden of the disease within the peritoneal cavity. And on the other hand, this also tells us about the completeness of the surgical cytoreduction. When we don't leave any disease behind, means we cannot see it. Microscopic disease is still there, but we are not able to see any gross disease, that is CC0. And CC1, which was defined by Sugar Baker, that was 2.5 millimeters. So that's how we have to be so accurate in knowing what we are leaving behind. And that's how the people have come up with the concern about the extent of the surgery, complexities of the surgeries involved based on the advanced nature of the disease, where the disease is, what kind of the complex nature of the surgeries can be performed, whether these are low, intermediate, or high. Look, people are looking at the different scoring systems, but not one scoring system can be used and can definitely be made as common scoring system to identify these. This was a scoring system which was actually, which was basically brought in by LET, and that's how we can predict that how extensive surgical procedures we will require to go for. Similarly, Fagotti, as was already said, in fact, it may not be possible many of the times to go for the laparoscopic evaluation when you see that the disease is advanced, simply because of a lot of adhesions intraperitoneally. You really do not reach to all these areas to assess. And it is not possible, this is not feasible. So actually, these are the scores where you can do it. Where you cannot do it, simply, I think these are the limitations. And Fagotti further modified based on actually these areas like diaphragmatic, mesenteric disease, or stomach infiltration, or liver metastasis. Looking at all these scores, and if suppose it is more than 4, look at these areas. If it is more than 4, think that, of course, you cannot achieve the optimal surgical cytoreduction. And that is how we became wiser after this NACT trial of the WordGut to choose the patients where we really cannot resect out the disease to that of the optimal status. And this, again, is based on those areas where we really cannot cytoreduce. So these are our limitations we must understand so far as going ahead with that of the surgical cytoreduction. And that's how this non-inferiority trial of WordGut, that was EORTC, which was published in 2010, this had become a landmark where they had selected the patients of the advanced stage of the disease, which was very bulky, and especially the upper abdominal disease. And then they compared with the primary surgical cytoreduction and the NACT. And they could find out that this was not inferior. Why it was taken as not inferior? Because the surgical cytoreduction is the mainstay in the management of the ovarian cancer. And that's how they compared it with that of the primary surgical cytoreduction. So whatever this evidence we have, it's not only for all the patients who are having just the ascites or the upper abdominal disease, but these are the patients where the disease is quite bulky in the upper abdomen. So it's important for us to understand this, that any patient who is having the ascites doesn't become a candidate for the NACT. And of course, along with this trial, there had been chorus trial as well. And both these trials have shown that these are non-inferiority trials. And they say that yes, in this particular group of the patients can be benefited equally when you are giving them the neoadjuvant chemotherapy. There are other ongoing trials as well, which are further looking into how specifically we can really select our patients and what is the impact on the survival. So as we have seen, already the histology and biological behavior of the disease we cannot change. But on the other hand, the only one modifiable factor, that is a surgical cytoreduction, which is going to extend the best in terms of the survival. You can see when we go for the advanced stage of the disease, this is how the upper abdominal disease is. Of course, the omental masses and all those things are very much there, but we have to go for peritoniectomies or the undersurface diaphragm peritoniectomy, diaphragmatic resections, and the number of other, you can say, procedures required to be done in order to achieve R0. You can see that here we have to even sacrifice this gastroepiploic arch, which is by the side of the greater curvature of the omentum. And whatever the disease is there into the peritoneum also requires to be totally resected. This is the visceral peritoneectomy as well. So whatever we are doing, what we are aiming at is no gross residual disease. Complete bladder surface peritoneum, of course, the complete pelvic peritoneum. Here I'm emphasizing on the bladder surface peritoneum. And that's how we try to reduce so that we don't see any of the gross disease in such area. Other than this, it is the retroperitoneum. This is again a matter of the debate. But yes, whenever the nodes are palpable and the bulky nodes, they require to be removed. We can't just think of that this is in the retroperitoneum, because once leaving the disease here, of course, this is going to affect so far as the survival is concerned. Though here again, I'm emphasizing that the actually Sugar Baker doesn't talk about this retroperitoneal disease at all. We are talking about the peritoneal, as majority of the patients will have the peritoneal disease. So this has also been debated. I think we have become wiser after knowing the number of studies, how to go about. So this is what is the modified, you can say the posterior exentration. And just to give you the glimpse of this video, where you can see that the disease is limited to the pelvis, but this requires the...
Ma'am, your time is up.
And in that case, actually, you take this as a unit of the involved colon and the uterus. And also,
Ma'am, sorry to interrupt you, but your
Can
time
we
is up.
just give her
Yeah, sure.
how long is, yeah, just give her a few
so I
minutes.
think this is how we go for the retrograde hysterectomy. And then we resect, we identify the part of the colon which requires to be resected, and we are ligating the superior rectal artery as well as the vein. And after ligating the superior rectal artery and the vein, we resect this, and then definitely, so that means we are identifying the part of the colon which is not involved with that of the disease. And that's how I think we define how much of the colon requires to be resected. So it is important to ligate this vascular supply earlier. Once we define this, we will come to know there will be a difference in that of the, can say, the look. The part of the colon which is affected by this blood supply will require to be resected out. So that's how this is ligated, and then we are using harmonic here. So this is the part of the colon which requires to be resected. We have already defined this, and this is how this is being cut. And of course, it is important to understand that how much of the length of the remaining sigmoid colon is there to re-anastomose, because it is modified posterior exentration, means we are going to go for the re-anastomosis as well, for this as a part of the cytoreduction. Here you can say the Walder's fascia, because what we are taking this as a unit, and we are deflecting the sigmoid colon anteriorly, entering into the, you can say, the Walder's fascia. The dissection is carried onto the Walder's fascia into the sacral hall. So we are taking out entire disease with that of the uterus anteriorly. And this is the clean area, which definitely requires the good dissection, and you can really resect it out very nicely. What you see here is the sacral promontory, and after this, what is important is one has to really save the hypogastric nerves as well. So entire this area, this requires to be dissected away. And as you proceed down towards the vagina, of course, this vagina is cut, and there is again the dissection between the vagina and the involved part of the rectum. In order to reach to the limit of the involved disease, here you can very well see this is the disease limit. So you have to go beyond this, that is distally, in order to resect the diseased area. And once anteriorly, you can see the bladder, and laterally are the ureters. And that's how you can see this area. This is the ureter. And this area, one has to take care of the ureter as well at the time performing this procedure. And that's how we can see that the entire, you can say, pelvis can be made totally free of the disease. This is the mesocolon. That's how we, mesorectum especially. And this mesorectum is basically divided at the place where we want to actually divide the colon, divide the rectum. So once we do this, we have to actually bear the rectal wall. Once we bear the rectal wall, here I'm using the circular stapler. And this is where we are using contour. With the contour, this is a stapler device. This makes your life very easy in going for the resection of this part of the rectosigmoid. And once it is fired, definitely the part of the entire diseased area along with the uterus and also the rectum and the colon, that definitely comes out. There is no spillage once you are using the circular stapler. Here you can see the entire pelvic peritoneum with that of the uterus and also the ovarian masses and infiltrating the rectum. So these are the kind of situations which this is what is the colon, the opposite, you can say the resected end of the colon. So entire diseased area can be out. And we find this kind of a situation in about say 6 to 8% of the cases. And we may have to go for this kind of the procedure, which is very, very important for all the GYN oncologists around. And that's how we can go for the anastomosis. We are taking the purse string sutures all around and using the anvil, I think, just expediting it. We can use the anvil, and after using the anvil, definitely we can go for the stapler anastomosis once we have done this. And this is where the anvil is. This is tied up, and this will be taken for the anastomosis. So these are actually the devices when we are using, we are taking the help. The chances of the morbidity of the leak that is reduced, but it's important that how we are doing this procedure. Of course, one requires a lot of experience for these procedures, but what I feel based on my experience that it is a thought. Once you are convinced, I think you will do it. So this is how we have been doing it, and we are following the principles, and that's how this anvil is then placed into the circular stapler, which is actually brought through the anus, and then we staple it. And this is the, you can see after the surgical cytoreduction completely. This is the ureter, this is the retroperitoneum, and you can see sometimes we do get, like in this patient, we had the accessory renal artery. So one requires to preserve that, otherwise the patient is going to be in real difficult situation. This is what is the accessory renal artery. So we have to take care of the surgical cytoreduction. Surgical cytoreduction in advanced ovarian cancer is really very, very long. And I'm really thankful for giving, actually, rather bearing with me for a few minutes more because of this video. And that's how
Thank you.
across. So these are all type of surgical procedures. I'm just winding up with only one concept. In Lion's trial, it has not shown any difference if suppose the nodes are not enlarged and you go for the lymphadenectomy retroperitoneal. So looking at the survival results at all, definitely we are not going to go for the retroperitoneal lymphadenectomy until unless they are enlarged. So at the end, what I would say is the optimal status of the cytoreduction in advanced ovarian cancer that should really be aimed at in order to extend the best survival results. This is the Department of Gynae Oncology at Fortis Memorials, Gurgaon. And with this, I thank you all.
Thank you, Dr. Rama. It was a wonderful oration. You gave a very informative talk, and besides that, that video was very useful, I'm sure, for everyone to realize and conceptualize that how important it is to find the disease extent and how to manage those cases which are very difficult and I mean really important for them. So thank you very much, and that video was wonderful.
Thank you.
Thank you so much, Dr. Rama, for that excellent video and the talk. It was very, very useful.
Thank you so much, Dr. Sarita.
Thank you, Chair. Thank you, chairpersons and the speakers of session 2. We go on to session 3. I request the speakers to please answer the questions in the chat box. So the audience is very interactive and they're asking a lot of questions. So Nilanjali, are you
Yes,
there?
ma'am. Yes,
Okay,
ma'am.
please introduce the chairpersons for the
Yeah.
next session.
That was a wonderful session indeed. So we move on to the next session, and for this I invite our chairpersons, Dr. Suman Sinha. Madam is Chairperson Vaginal Surgeries Committee FOXY 2024-2027. She is Director Advanced Care and Maternity Center Ranchi and Senior Consultant IVF at Infertility Center Ranchi. She has had multiple awards, International MS Signature Award, Dr. Durusha Appreciation Award, and many such awards to her credit. She has various publications and has been organizing chairperson of various important meetings, including FOXY East Zone Conference for year 2022. Welcome, Madam. Now I'd like to take the opportunity to introduce Dr. Kavita Baranwal, our next chairperson. Madam is Senior Consultant and Laparoscopic Surgeon, Samarpas Hospital, Munger. She's a chairperson of Urogyne and Pelvic Floor Repair Committee, FOXY 2024-27, Associate Professor, Lord Buddha Koshi Medical College, Saharsa. Madam is a recipient of Padma Bhushan Kamla Bai Hospital Award, and she has also many other awards to her credit. She has been organizing secretary of the 9th AOG SBJ in 2022. Welcome, Madam. Our next chairperson is Professor Pratibha Singh. Madam is consultant laparoscopic gynecologist and IVF specialist, Director Healing Touch Hospital, Bhagalpur. Madam is chairperson of IAEC FOXY 2022-25, chairperson Fertility and Aging Committee, IMS 23-24. She has been president of Bhagalpur Menopause Society. She also has been organizing secretary of various very important meetings and has multiple awards to her credit. Welcome, Madam. I would now request the chairpersons to carry on the session.
So should I introduce?
So I will introduce Kavita. Just
okay.
So thank you, Dr. Sarita Samsundar, for the lovely opportunity and such a well-crafted program you have made it. You have covered the A to Z of ovarian tumor, and all the speakers, they have done justice, super justice to their talk, and it is so clear. So I take the opportunity to introduce the first speaker of the third session, and she is Dr. Neeta Khurana, and she will be talking upon the pathology of ovarian tumor. So Dr. Neeta, kindly go ahead with your talk. So can I introduce Neeta? Hello? Just a minute, please. Yeah. Dr. Neeta Khurana is the Director, Professor and Head, Department of Pathology of Maulana Azad Medical College, New Delhi. She's been the honorary faculty member, Department of Medical Education, and she has huge experience of around 29 years for the undergraduate and 27 years for the postgraduate teaching. Has so many publications to her credit, and she's life member of so many organizations, and her special interest is in surgical pathology and immunohistochemistry, FGT, skin, breast, and soft tissue. She's been awarded with the Eminent Medical and Health Education Teacher, awarded by Delhi Medical Association. So, over to you, Dr. Neeta.
Thank you so much for the kind words, and I thank the entire organization and especially Dr. Sarita ma'am for giving me this opportunity to interact with the audience. So I hope I'm able to share my presentation.
Yeah, just make it full screen.
Yeah, sure. So this is full screen now, ma'am. Thank you so much. And again, with the thanks, the topic given to me was the pathology of ovarian tumors. And I'm really thankful to all my clinical colleagues from my gynecology and obstetrics department. And Dr. Sarita was part of MAMC previously. So she had also been sending us many ovarian tumors for the complete resections. And as the previous speakers have given us a detailed view of the various cytoreductive surgeries which are being done. So we have been fortunate to learn from all those cytoreductive surgeries. So going on to the basic pathology of the ovarian tumors, as we will be discussing it today. So let me first start with the basic schematic diagram of what the ovary looks like. So ovary being a structure which is lined by the surface epithelial cells as has been shown over here. I hope you can see it over there. The other important cells which are present are the germ cells. So then the second group of tumors which we have are the germ cell tumors. And then we know that the stroma which is present, the ovarian stroma which is present will be a part of the ovarian stromal tumors. And these are the three important set of tumors that we will be dealing with. And most of the surgeries which have been shown to us are from the surface epithelial tumors. Coming to the surface epithelial tumors, which is also called as the germinal epithelium, we have three main important groups, which are the serous tumors, mucinous tumors, and the tumors showing differentiation towards the transitional epithelium, which are the Brenner's tumors. And the fourth important group is the endometrioid tumors, which resembles similar to what you have the endometrial tumors in the uterine corpus. So these are the four important tumors which arise from the germinal epithelium, and all of them can be categorized from benign, borderline to malignant, and the complexity of the anaplasia and the invasion which makes it malignant, while lack of invasion makes it benign, borderline, while the benign tumors do not show any features of anaplasia. The other important group is the germ cell tumor, of which we keep on seeing the most common tumors being the dermoid cyst or the teratomas, which are the most important ones. And then sometimes we can have malignant transformations in the teratomas. The malignant germ cell tumors are the dysgerminomas, which are counterpart of the seminoma of the testes. Then we have yolk sac tumors, choriocarcinomas, and embryonal carcinomas. Now, all these arise from the ovarian germ cell. But when we come to the layers of the follicles, we know that there are granulosa cells which are forming the layers of the follicles, and the theca externa and the theca interna cells. So from these gonadal stromas, we have the thecomas and the fibromas, which come as solid ovarian tumors. Thecomas being lipid filled, so appear more yellow on gross appearance, while fibromas appear dense white on gross appearance. The malignant tumors of these ones are the granulosa cell tumors and the Sertoli Leydig cell tumors, which we see uncommonly, but can be a source of chemotherapy, should be requiring chemotherapy, especially in the malignant cases. Then the uncommon tumors are the Hyler cell tumors, which are usually the benign tumors, and very rarely we can have the vascular tumors and the leiomyomas, which arise from the ovarian hilar stroma and from the ovarian vessels which are coming from it. Now, why do these tumors develop? What is the pathogenesis behind it? There are various theories which have been proposed for the development of ovarian cancer. Some which negate each other also. The most important theory which has been proposed is the repeated trauma to the surface epithelium. And as a result, the surface epithelial tumors are the ones which are the most common ovarian tumors. And this is because of the incessant ovulation therapy. So repeated ovulations, that means repeated trauma to the germinal epithelium, leading to accumulation of mutations, and that would lead to surface epithelial tumors. The second theory which has been proposed is the gonadotropin theory, which will lead to increased estrogen excess, and that is what will lead to estrogen dependent tumors, especially the endometrioid tumors, similar to the ovarian tumors which is there, and may also be seen with the PCOD patients. The third and the most important theory, which came on much later and is the most favored theory these days, especially for the high-grade serous carcinoma, is the fallopian tube theory. That actually the tumor, which is the fallopian tube serous carcinomas, are arising from the fallopian tube epithelium, and that is why it is important to see the pre-neoplastic changes and the neoplastic changes in the fimbria of the fallopian tube. Now, apart from this, we know that the ovarian tumors, as our previous speakers have also told us, are the important ones, which are the low-grade serous tumors, mucinous, endometrioid, and clear cell tumors and transitional tumors. All these are grouped as type 1 tumors. These type 1 tumors are stable genetically. So they have a RAS MAPK pathway through which they develop these tumors. And the precursor lesion is considered to be the epithelial inclusion cyst, which can be explained by the incessant ovulation theory. While the type 2 tumors are more aggressive, they are high grade. They can be high grade serous carcinomas, undifferentiated carcinomas, or even the mixed Mullerian tumors, nowadays called by WHO as carcinosarcomas, the mixed Mullerian tumors not being preferred, the terminology these days. These tumors are high grade, have an unstable landscape. Majority of them, nearly 4/5 of them, 80% show a P53 mutation. And these are the ones which are associated with BRCA1 and 2 abnormalities. So these are the ones which will be showing the germline mutations, as we have seen in the charts, and should be done. The germline mutation testing should be advised to the family of these patients. The precursor lesions of these tumors is the one which is arising from the epithelial cells of the ovarian fimbrial tube. So from the fimbriae of the fallopian tube. So this has been there. The good thing about these high-grade tumors is they are sensitive to platinum chemotherapy and the PARP inhibitors. Because they are high-grade tumors, so they are sensitive to chemotherapy. So where does the pathologist come in? The pathologist comes in both in the pre-operative consultation and majority in the intraoperative consultation, because most gynecologists do not prefer a fine needle aspiration because that may rupture the capsule and may lead to spread of the tumors. Intraoperative consultation, especially at the time of cytoreductive surgeries, especially in early ovarian cancer when one is not sure of whether the benign or whether it is borderline or malignant tumors, so should always be subjected to frozen sections. If frozen section facility is not available, scrape cytology can give you a very fair idea to an experienced pathologist whether we are dealing with a frankly malignant tumor or not. The other experiences which we have in our setup are the crush smear cytology, intraoperative FNACs, imprint cytology smears, and of course, the malignant cells in the cyst fluid as well as the malignant cells in ascitic fluid, which is the routine part of the staging procedure and can be done intraoperatively also. So the reason for doing a frozen section is one, for diagnosis, two, knowing the extent of the disease, whether there are actually peritoneal deposits or there are peritoneal mimics of deposits like endometriosis or tuberculosis, or there are just fibrotic nodules. Maybe it is not a true metastatic disease, and to look for the adequacy of resection if you are dealing with the fallopian tube extension. So just showing you the gross pathology changes. So this was an ovarian tumor in a 22-year-old girl who had come with the simple ovarian cyst. The surface was clean, smooth, no capsular breach, wall was thin, there were no mural nodules. So one should always look for, even in a completely cystic tumor, whether there is a small mural nodule which may show malignant. The other thing, if you have not been able to give the complete cyst to the pathologist, look out for cyst contents and mention the cyst contents, whether they are serous, mucinous, or hemorrhagic, because that will give you a fair idea what kind of, whether it is a serous or a mucinous tumor you are dealing with. So the mucinous tumor shows you the tall columnar mucin secreting lining with a basally placed nuclei in a benign one. And in a malignant one, you will have high-grade nuclear features of anaplasia and mitosis. While in serous tumors, we will get the surface cilia, similar to what you get in the respiratory epithelium or the fallopian tube epithelium. In multiloculated complex cyst, as a pathologist, we open up all cysts to look for any areas which have solid components or there are any papillae which are present, because these are the areas which should be looked out for, cut, and processed to look for any malignancy, especially in mucinous tumors, because in the same tumor we can have benign areas and malignant areas. So do ask your pathologist whether they have taken at least one section per centimeter of the tumor before calling it benign or borderline, because malignancy can be picked up easily. It is the later ones which would be there. So presence of this cilia on top, papillae formations, multiloculations, stratification, and high-grade nuclear anaplasia, mitosis, and atypia are the ones which will, with features of invasion, which will make it a malignant tumor, while benign tumors will show benign morphological features. So this is what we see under the microscope: multiple papillae with fibrovascular core, There are high-grade nuclei which are there, large nuclei, atypical nuclei with atypical mitotic figures. These are the ones which make us diagnose the malignant surface epithelial ovarian tumors, which of course you can see it over here, which are present. And sometimes we may even do mucicarmin stain and immunohistochemical stain for mucin if it is a poorly differentiated carcinoma, whether it is serous or mucinous type. Because the high-grade serous will be requiring much more aggressive chemotherapy. Now, apart from the cystic tumor, sometimes you may have a completely solid tumor, or there can be predominantly solid tumor with cystic foci. It is good to send the tumor in entirety because then the capsular breach can be identified by the pathologist. If at all you have not been able to remove it in entirety, please mention whether the surface which is there, the capsular breach has occurred or not, because that will be a very important part of your staging procedures. So what we do is we ink the capsule and then take the section to look for any capsular breach which is present or not. And this was a mucinous cyst adenocarcinoma which was there in this tumor. And here one can see that both the tumors bilateral ovaries were removed and there were extensive surface proliferations. Of course, there were areas of intact capsule also. So this was from the bilateral malignant mucinous cyst adenocarcinomas. This was a high-grade serous cyst adenocarcinoma, completely solid with very few small cystic areas which had the serous fluid. So sometimes the high-grade serous carcinomas may look completely solid tumors, but they will not be dense fibrous like fibromas. They will be small, they will be friable and softer in consistency, which you can even pick up when you are cutting it from the knife. Now, this was a radical hysterectomy which was done. One can see the uterus with the cervix and bilateral mucinous cyst adenocarcinomas. One can see the mucinous contents in the various loculi and of course with the solid areas as well. So this was another tumor which can show a solid cystic appearance with tumors showing, and there will be areas of necrosis as can be seen it over here. So we do look for areas of necrosis both in the primary tumor and after neoadjuvant chemotherapy, because after neoadjuvant chemotherapy, the chemotherapy response will be in the form of necrosis, fibrosis, and inflammatory infiltrate. So if you have, the patient has been lucky and you have been able to give neoadjuvant chemotherapy, there is reduction in the tumor size, the reduction in the ovarian size, then we look for tumor bed and tumor bed response and show it as a pathological complete response, partial response, or no response. That is how we report the post-chemotherapy tumor specimens. So now over here, we can see that there are large papillae which are even infiltrating the capsule. So capsular infiltration and lymphovascular infiltration are two important things which we always look out for the ovarian tumors, and these should form the part of the standard reporting that you get from the pathologist. So serous tumors can sometimes show these calcifications which are called as the psammoma bodies, apart from the formation of these large glandular areas in well-differentiated tumors. And in poorly differentiated tumors, we will get just sheets of cells without glandular formations. So this is about the tumors of the surface epithelium. To summarize, serous are the ones which resemble like the fallopian tube lining with cilia on top of the surface. Mucinous resemble the endocervical mucinous lining. Endometrioid resemble the endometrial lining. Clear cells resemble the endometrial glands during pregnancy, and transitional cells which resemble like the transitional epithelium of the urinary bladder. So these are the important 5 groups of the surface epithelial tumors. And like our previous speaker has said, these are the most important tumors, and malignant tumors bilaterality is common in malignant high-grade serous carcinomas, or to the extent of 2/3 of these cases can be bilateral. The high-grade serous tumors will show p53 mutations and WT1 mutations. Immunohistochemistry is available for both of these. You may not need to go in for molecular study. And we usually use IHC surrogates for classifying low-grade versus high-grade serous carcinomas by doing immunohistochemistry for p53 and WT1. So these are the two important things that we always look out for. Coming on to this another case, here you can see the uterus is a postmenopausal one, very small, tiny, but we have bilateral solid large ovarian masses which was removed from that. And when we looked at the microscopy, these were mucinous adenocarcinomas in both the ovaries. And when we did an endoscopy, advised an endoscopy for this turned out to be a gastric carcinoma metastatic to both the ovaries, and the spread can be transcoelomic spread to bilateral ovaries, leading to bilateral Krokenberg tumors. So this could be a mucinous tumor, but of the origin from there. Just a couple of cases which I will show you. This patient had no ascites, but a 7 into 6 centimeter mass, and CA125 was raised. So, and this was the crush smears which we prepared from the tissue which was provided to us from the, and this showed to be a mucinous cyst adenocarcinoma.
Ma'am, sorry to interrupt you. Your time is up.
Yeah, I'm just going on
Just
to
a
one
few
interesting
minutes.
case.
Yeah.
So this was a teratoma which was there in a 28-year-old lady, was seen shown calcification on X-rays, and one can see cartilage, glandular epithelium, as well as the skin epithelium or the stratified squamous epithelium. So mature cystic dermoid teratomas. Sometimes they can show hyperthyroidism with struma ovari formation, or even carcinoid when we call it them as monodermal teratomas, and rarely they may show malignant transformation. If they show trophoblastic differentiation, we call it choriocarcinoma. When they show extraembryonic differentiation, we call it yolk sac tumor. And when they show germ cell differentiation without any other thing, we call it dysgerminoma, as was shown to us in this one. So this patient had Schiller dual bodies on microscopic examination, 8-year-old girl, which had a yolk sac tumor with highly raised alpha fetoprotein levels. Even if the tumor markers had not been done previously, and this was a component of a part of teratoma, we can do alpha fetoprotein immunohistochemistry to make a diagnosis of the yolk sac tumor. So this is another case which is seen in a 11-year-old girl, and one found that beta HCG levels were slightly raised, and that beta HCG levels were raised in this patient of dysgerminoma because syncytial trophoblastic cells can be present in the septa of dysgerminoma. So that should not take you away that this young girl is having a trophoblastic malignancy or a choriocarcinoma, because these patients with dysgerminoma are extremely radiosensitive, and small amount of HCG can be raised in these patients. A case of solid ovarian tumor, easily diagnosed as fibroma, which would be a spindle cell tumor on microscopy and easy to look out at it. If it is a thecoma, frozen section examination will show you lipid present in these cells. So both would be benign tumors. Uncommonly, we can get the granulosa cell tumors, both in reproductive age group, which would be the adult granulosa cell tumors, and sometimes in young children, 10 to 12-year-old with juvenile granulosa cell tumors. So one should remember that juvenile granulosa cell tumors may also be seen in these patients. So sex-cord stromal tumors, uncommon, but can be seen in young girls. So a mental biopsy has been extensively described by our previous speakers. So one should know that peritoneal implants and surface epithelial tumors can be non-invasive or invasive. And if invasive tumor implants, the progression-free survival is just is very high. The rate, the aggressive treatment is to be required for invasive implants rather than for non-invasive implants. So with or without treatment, the progression-free survival is 94% for more than 4 years. So diagnosis of ovarian tumors, all clinicians of you know it, so I need not repeat it. But tumor markers, ascitic fluid cytology, and histopathology, which would remain the gold standard. I would still suggest that ascitic fluid cytology or an FNAC or a biopsy should be done before giving neoadjuvant chemotherapy, because after the chemotherapy response, we may not be able to find out the primary tumor histomorphology, which would be difficult to do it. So one request as a pathologist, when you send the tumor for histopathology, for frozen sections, do not add any fixative. When you are sending it for formalin sectioning, for a permanent sectioning, please send it in 10% buffered formalin, 10 times the volume of the tissue, which would be like this and not stuffed up like this, because this will cause autolysis of the specimen and we will not be able to give you any diagnosis. So with that one request as a pathologist to all the surgeons, I'll close my thing and would like to take any questions if there are. Thank you so much for this opportunity. Thank you, Dr. Sarita, and all the chairpersons for their kind words.
Thank you, Dr. Neeta. Can you please remove your slides?
Yeah, sure.
Yeah. Yeah. Stop sharing. Yeah.
Yeah, stop
It
sharing.
was really lovely presentation. And you have elaborated each and everything so nicely. And the take-home message is very nice because we are fumbling that how to send the specimen, especially during frozen section. Now it's quite clear that we don't have to add any fixatives while sending for the frozen section, and while sending for the histopathology, we'll have to 10 times. No, you said 10 times of
Yes, 10 times the volume of the
volume
formulate.
of the specimen. This is very important. And
So-
these days, as you have said, we depend upon the tubal pathology. So while even doing the benign hysterectomies, we're trying to remove the fallopian tube so that to prevent.
Yes, definitely. We are getting them and
so lovely messages from you. And thank you once again, Dr. Sarita, for involving me.
Yeah, thank you so much for this. If there are any questions in the chat, I'll
any
take
questions
them.
or
Yeah,
I'll
Dr. Nita, if
respond
you
in
can
the
tell
chat
them
if there are any questions.
that
I
we
think we are
can.
running short of time, so we'll take over the second.
Maybe you can
In
ask
the
them
end, yeah, and the chat
about
box
the
questions can be put in.
Yes, yes.
So thank you, Dr. Sarita Shamsundar, for giving me the opportunity, and I must congratulate for putting such an important academic program. You are touching every aspect of the ovarian tumor. So this is really well crafted, and I wish the success. So now, after pathology by Dr. Neela Khurana, Dr. Sachin Khurana will be speaking on new adjuvant and adjuvant therapy of the ovarian cancer. So he is Associate Professor Medical Oncology in AIMS, New Delhi, and he had done DM in Medical Oncology from Tata Memorial Hospital, Mumbai, MRCP from UK, and Fellowship Phase 1 trial, Royal Marsden Hospital, London. So with these words, I invite Dr. Sachin Khurana to speak on new adjuvant and adjuvant therapy. So now the dais is yours. So welcome, Dr. Sachin.
Thank you, ma'am. Let me just share my slides. Are my slides visible?
Yes, it's visible. So
Thank you, ma'am.
Yes, that's good.
Thank you, ma'am. And thank you, Sarita, ma'am, for giving me the opportunity to speak here. So I'll straight away start with my presentation, and it's about neoadjuvant therapy in ovarian cancer. I'll skip a bit of part just to let you know, we all know ovarian cancer is one of the common malignancies and associated with high morbidity and mortality. I'll straight away start with a case. Let us assume there's a 60-year-old female with who presented with abdominal distension and discomfort and a lot of upper abdominal disease and C1251080 with the effusion also present and proven cytology positive. So now, how to approach such a case which have the patient has extensive disease and especially extensive disease in the upper abdomen. So here comes the role whether we should approach with the primary surgery or NSCT. Rama ma'am in her talk has already outlined two important trials which help us to decide whether we should go for primary surgery or NSCT. Actually, these were the two trials which introduced the concept of NSCT. So I'll again touch upon these trials. This was the trial by Vergot, published in 2010, and they randomly assigned their patients to either primary surgery or neoadjuvant chemotherapy. And what they noted that the outcome, the survival was similar in both the arms, but the rate of optimal cytoreduction increased in those patients who received NSCT. But the survival outcomes were same. So this established that giving NSCT is feasible in ovarian cancer patients. Previously, it used to be primary surgery standard of care followed by adjuvant chemotherapy. The other trial, this was also touched upon by Rama ma'am, and it was the Chorus trial. It was again a non-inferiority trial, and it also established that giving NSCT is non-inferior to primary surgery in ovarian cancer. Again, it also showed that the morbidity after surgery is less when NSCT is given. So after these two trials, NSCT was increasingly used across the globe, I would say, for ovarian cancer patients. But how to decide which patient should go for NSCT and which patient should go for primary surgery? Well, it is a little relative, but I would say that there are certain absolute indications which I hope all the surgeons here would agree with me, like poor performance status, poor nutritional status, root of mesentery involvement, stage 4 disease, be it parenchymal liver or lung disease, and when extensive intestinal infections are required. These, for me, are absolute indications, and I hope and I think that most of the surgeons will agree to that. But the most important thing while deciding for NACT is whether a CC0 dissection is feasible or not, and that should be based on an assessment in an MDT, predominantly by radiologists, by the surgeons, and should also include other people like medical oncologists and also the palliative care physicians and everybody. But the most important assessment is by gynae-onc surgeon, whether a CC0 resection is feasible or not, and that should take the things forward, whether to give NACT or adjuvant chemotherapy. So, just for all the students, what are the drugs which we use in as chemotherapy in ovarian cancer, be it NACT or adjuvant? The most important drugs are paclitaxel and carboplatin. Sometimes when giving paclitaxel is not feasible, say because of pre-existing neuropathy or the patient develops a hypersensitivity reaction to paclitaxel, the alternatives are liposomal doxorubicin and docetaxel. Can we use bevacizumab during the course of ovarian cancer? I will discuss in my next slides. Next is, what is the optimal number of cycles? See, both these two trials, the Vergot and the Chorus, the landmark trials which established that NACT is not inferior to primary surgery, they use 3 cycles in NACT and 3 in adjuvant. But what is widely accepted is that 3 to 4 can be used in NACT and at least 3 should be given in adjuvant setting. So overall, ideally 6 cycles, but in NACT you can use 3 to 4. But yes, the guidelines say if you assess that it may not be possible to do a surgery even after 3 cycles, you can go on up to 6 cycles in selected cases only. So, but try to give 3 in neoadjuvant and 3 in adjuvant setting. So there are some texts which also mention about dose-dense therapy. Just to introduce what exactly is dose-dense therapy. Now, before that, I would like to tell that these drugs are used every 3 weekly. So giving paclitaxel at 175 mg per meter square and carboplatin AUC 5 or 6 given every 3 weeks for 6 cycles, 3. What is dose dense then? Dose dense means that we are administering chemotherapy with less time interval between the treatments. And for ovarian cancer, there have been 2 ways we can do that. One is that carboplatin being administered every 3 weeks and paclitaxel every week, or both carboplatin and paclitaxel being administered weekly. So there have been few trials. I will not go into the details of those trials. They showed increased PFS and even OS in one of the Japanese trials, but they were also associated with higher toxicities, the weekly regimens, the dose-dense regimen. So the usual preference among all clinicians worldwide is the conventional 3 weekly dosing, where we can use a kind of a modification of dose-dense treatment. I will come to that later. So this was a trial which it was named as MITO-7 trial. It actually randomized patients between weekly dosing and 3 weekly dosing. The dose used in the weekly dose dense regimens, which were actually the dose dense regimens, the paclitaxel dose was 80 mg per meter square weekly, and carboplatin 3 weekly, AUC 5 or 6. This modified that regimen and used the dosing of paclitaxel 60 mg per meter square weekly and carboplatin AUC 2 weekly. So practically dividing the 3 weekly dose into 3 parts. What they observed that the side effects were actually less in this modified dose dense regimen with the lower dose of paclitaxel. And see, what I have highlighted here is the patients who are more than 70 years. In patients more than 70 years, if you see, weekly regimen was favored in terms of outcomes. Why? Because weekly regimen with paclitaxel of 60 mg per meter square was associated with less toxicity. So now it has become a very common practice to use a weekly regimen, especially in those patients who are elderly or who are in poor general condition, and the clinician thinks that she may not be able to tolerate a 3-weekly regimen, a higher dose regimen. So that's where we can use a weekly regimen in ovarian cancer patients. Otherwise, the standard of care remains a 3-weekly regimen. Now, sorry. So now, what about bevacizumab? It is now being widely used in ovarian cancer, but what actually is the data for that? So there were 2 trials of bevacizumab in first-line setting for ovarian cancer. One was the GOG trial, another was the ICON 7 trial. This is the GOG trial. So important to note, there was a PFS difference. PFS was higher in the bevacizumab population, but the overall the OS was same. So there was no overall survival difference between bevacizumab versus no bevacizumab as maintenance therapy. This was the second trial, the ICON 7 trial. This also showed no overall survival difference in the whole population, but in a high-risk population, it showed that bevacizumab patients behave better. The outcome was slightly better. And what were these high risk? These were stage 4 patients or who had suboptimal cytoreduction. So the doses used were different in these 2 trials. ICON 7 used a dose of 7.5 mg per kg and GOG 218 used a dose of 15 mg per kg. So, these 2 trials were in the adjuvant setting. So bevacizumab was started with chemotherapy and continued as maintenance for 1 year. Can we use Bev in neoadjuvant setting? So there's not much data, but there are few trials which have shown that it is feasible and safe to give bevacizumab during NSCT also. But what it does, it increases the response rates, but there are no survival differences. So where should we use bevacizumab? What's the gist of all this data? It is optional in NSCT, maybe in cases which have massive ascites or effusion. In adjuvant setting, can we use in all stage 3-4 patients? There is no OS benefit demonstrated. But yes, in high-risk patients in ICON 7 trial, OS benefit was demonstrated. And what are these high-risk patients? Stage 4 disease, suboptimal cytoreduction, or massive ascites and effusion. So these are the patients where we can use bevacizumab in ovarian cancer. Now, but in spite of the best efforts, the median PFS of ovarian cancer patients is 12 to 18 months. So there is definitely need for something more, and insights into homologous recombination repair have changed the way now we treat ovarian cancer. And what is that? We all know that DNA is constantly damaged and repaired, and the important 2 pathways are the single strand break repair and the double strand break repair. This is by base excision repair for single strand breaks, and the DSP repair using homologous recombination enzymes. So just focus on this base excision repair, seed enzyme, PARP1 enzyme. So this is involved in the repair of single strand breaks. And the BRCA1, BRCA2, and other homologous recombination repair enzymes are used in the double strand breaks. So just remember these 2 pathways of single strand break and double strand break repair. And now we'll try to understand the concept of synthetic lethality, which has actually introduced PARP inhibitors. And what it means is, in a normal cell, when both the ssDNA break repair and dsDNA break repair are intact, the cell viability is good. If there is one of the mechanism is deficient, still the cells are viable. But if both the mechanisms are deficient, that is, these are HR deficient cells or PARP enzyme is inhibited, then it results in cell death. So this is synthetic lethality. And just to highlight the terminology, which is sometimes confusing when we are deciding which patients should be given PARP inhibitors, how do we decide? Just understand this terminology. What is HRR? It's homologous recombination repair, which is an error-proof DNA damage repair pathway. What is HRP? These are cells which are homologous recombination proficient, and these cells are able to repair DNA damage, especially the DNA double strand breaks, by homologous recombination repair pathway. Enzymes I just showed you were BRCA1, BRCA2, and other enzymes like ATM, BRIP1, etc. What are HRD cells? These have homologous recombination repair pathway deficiency because of some mutation. What do you mean by HRD positive? That means that we have demonstrated that the homologous recombination repair pathway is deficient by some test. HRD negative means we are not able to demonstrate that the cells have a homologous recombination repair pathway deficiency. The test I will just tell you. So again, now homologous recombination status is actually made of two things. One is cause of the deficiency and other is a consequence. For us, important is the consequence. The cause can be either a mutation or it may be some epigenetic modification or anything. We need to see the consequence. And how do we see that consequence? By way of genomic scars or mutational signatures. I'll skip this. And so this consequence means what is the phenotype. We are not worried about the genotype. We are worried about the phenotype. And this is the standard test which was used, and it is the myriad assay for HRD. It uses loss of heterozygosity, telomeric allelic imbalance, and large-scale state transitions to classify patients who are HRD positive or negative. So they look basically into genomic scars which are created by certain reasons. It may be genetic mutations or epigenetic alterations. So we have seen that up to 50% of high-grade serous ovarian cancer patients have some form of homologous recombination deficiency. I'll skip these parts and I'll just move on to PARP inhibitors. So this introduced the concept of PARP inhibitors, and the first drug which was used was olaparib in the SOLO-1 trial, where in BRCA mutated patients, they used olaparib as maintenance, and they see that and they saw that it was a dramatic improvement in the PFS as well as OS of ovarian cancer patients. So the important side effects of PARP inhibitors, the most common I will just highlight: nausea, fatigue, vomiting, and anemia is the most common reason for dose reduction. So the landmark trials which have used olaparib and other PARP inhibitors are SOLO-1, Prima used niraparib, Paula-1 uses olaparib plus bevacizumab, and Athena Mono used rucaparib. So these three PARP inhibitors are most commonly used: olaparib, niraparib, and rucaparib. Niraparib is not available in India. Olaparib and rucaparib are used in India. So the important thing I want to highlight in the results of these trials is the population which do benefit from that. So one are the BRCA mutant. So they derive the maximal benefit. You to see the difference in PFS: 56 versus 13.8, 37.2 versus 21.7, 22 versus 11. So they are the patients who derive the most benefit, the BRCA mutant population. Then HR deficient, I told you how do we identify by the test, and they also have good improvement in PFS with PARP inhibitors. I'll just take 2 more minutes. So important to understand is the HR proficient population, which are negative by that test, the myriad test or other modifications of that test. That means that the homologous recombination pathway is not damaged in those patients. They have the minimal benefit from PARP inhibitors. So only a 3-month PFS was observed. So and a meta-analysis from India, from Tata Memorial Hospital, showed that the patients who are HR deficient or BRCA mutated are the patients who will benefit from PARP inhibitors, and not the HR proficient patients. So what are the indications for PARP inhibitor in ovarian cancer? As maintenance therapy in BRCA mutated ovarian cancer, maintenance in HRD positive patients. And let me tell you, HRD positivity is defined by either that score which I showed you in the myriad test, the genomic scar score, or mutations in tumor BRCA. So both BRCA mutated patients and who have a higher genomic scar score, more than 42 defined in the myriad test, they are termed as HR deficient, and we believe that they have their homologous recombination repair pathway is deficient, and these are the patients who will derive most benefit with PARP inhibitors. So what about HR negative? It is approved by certain agencies, but if we compare the risk versus benefit, they do not go in favor of PARP inhibitors, and that was also proved in that meta-analysis. Can we combine bevacizumab and PARP inhibitor to have some more effect? Yes, one of the trials showed that it is feasible to combine bevacizumab with PARP inhibitor. It also showed that adding PARP inhibitor in HR proficient patient was not beneficial. So just to understand that you can combine, it is feasible to add PARP inhibitor and bevacizumab, but maximal benefit will be derived in those patients who are either BRCA mutated or HRD positive. Now, how do we take our decision? So this is a summary slide. First decision is whether we are using bevacizumab or not in our primary therapy. If we are using and the patient is, if we are not using and the patient is BRCA mutated, she will go on to receive a PARP inhibitor. If they are not BRCA mutated, then you can use niraparib or rucaparib. But first do an HRD testing. If the patient is HRD negative, the benefit of PARP inhibitor is minimal. If a patient is HRD positive, the benefit of PARP inhibitor is good. Next is, if you are using bevacizumab as part of primary therapy and patient is BRCA mutated, you can either combine olaparib with bevacizumab, or you can just use PARP inhibitor. You can even take off bevacizumab. If the patient is not germline BRCA but HRD positive, again you can add olaparib. But if the patient is HRD negative, the trials have shown that there is no additional benefit of adding a PARP inhibitor to bevacizumab in HRD negative patients. So more or less in HRD negative patients, if you want to use some maintenance, you can use BEV. And in HRD positive or in BRCA mutated patients, you can use either bevacizumab plus PARP inhibitor or only PARP inhibitor as maintenance. So just to summarize, neoadjuvant therapy is equivalent to primary surgery in terms of survival outcome, but results in more optimal surgeries. Decision should be taken in MDT after detailed assessment by surgeon, radiologist, medical oncologist. Most effective drugs remain taxane and platinum. Bevacizumab can be added in high-risk patients. PARP inhibitor are now standard of care in maintenance therapy in HRD positive and BRCA mutated. And in select cases, you can add bevacizumab to PARP inhibitor as maintenance. So I conclude my talk here, and any questions are welcome. Thank you very much.
Thank you, Dr. Sachin, for such an elaborate discussion, which I am listening to the first time, because we are not practicing oncology. So many things are new for me. And at last, I could understand that neoadjuvant therapy followed by debulking surgery has as good result as primary debulking surgery. So thank you so much. I think the persons who are practicing oncology, they will be benefited. It's though new, but I could understand. And I would like to refer the patient to you so that our patient can get maximum benefits. So thank you so much for joining and for highlighting all the points. Thank you.
Thank you, ma'am. Thank you very much.
Once again, thanks to Dr. Sarita Samsundar. So, Pratibha, are you there? So, Dr.
Dr.
Kavita.
Sachin, please answer any questions
Hello.
in the chat
Yeah.
box.
Can you listen me? Hello.
Sure, ma'am. Sure,
Yeah,
ma'am.
yeah, yeah.
So
Dr.
good evening,
Pradeep, are you there?
everyone.
Yeah, okay.
Thank you, Dr. Sarita, for including me in this program, and my regards to our chief guest, Dr. Sarita Bhale Rao, Dr. Sheila ma'am, Dr. Parag, Dr. Chamila, and Dr. Sarita. Congratulations for designing such wonderful and so informative certificate course on oncology. So really, it is really very informative. And now she is professor and head of department of Obs-Gynae, CMC and Hospital Ludhiana. She is also vice president Ludhiana Obs-Gynae Society and president Ludhiana Menopause Society, secretary Punjab chapter NIGF.
Then keep it short, Dr.
And editorial board member. And she has gone, and she has been, her CV is studded with lot of awards and honor. So welcome Dr. Kavita Bhatti, and she will be talking on ovarian germ cell tumor, which is a rare but unlikely the epithelial ovarian cancer. They can be detected. Tumors are mainly seen in the children and adolescent. And if you treat it effectively, I think 95% it carry cure rate. So with this, I'll invite Dr. Kavita for her talk.
Thank you, Dr. Pratibha, for the kind introduction.
Over to Dr. Kavita.
Yeah. Can you see the screen? Hello?
Not
Hello,
yet,
yes.
not yet.
Yes, no. We cannot see you.
Can't. Now?
Yeah, we can see.
It's visible and I'm audible?
Yes, you are audible and the screen is visible.
Okay, thank you so much. So after listening to all the malignancies, I think germ cell tumors, talking about germ cell tumors, little reassuring because we see most commonly in the young age group, and most of them are benign. And even if they are malignant, they have a good prognosis. So ovarian germ cell tumors, which are derived from the primordial germ cells of the ovary, I think Dr. Nita had already elaborated on that. It constitutes 15 to 20% of all ovarian tumors and 5% of all ovarian malignancies. And it is most common in the first 2 decades of life. 70% of these ovarian tumors are of germ cell origin if you see them in the second and the first decade of life. And out of these, 1/3 are malignant. Teratoma, we all know, is the most common, and it is 95% benign. 5% may have a malignant transformation. So basically, the germ cell tumors, which are composed of different tumor types, are derived from the primitive germ cells, and they can differentiate into various tumors if the germ cells that has not acquired the potential for further differentiation, then they stay as seminoma of the testes or dysgerminoma of the ovary. But some of the totipotential germ cells can also differentiate as embryonal carcinoma. If they go on to the extra embryonic development and germ cell lines, then it may differentiate towards vitelline structures, going on to give rise to yolk sac tumors, or they may differentiate towards trophoblast and give rise to choriocarcinoma. If it develops on the embryonal differentiation, then they give rise to the teratomas. So this is the classification of the germ cell tumors of the ovary. We all know dysgerminomas, endodermal sinus tumors, which is now known as yolk sac tumors, embryonal carcinomas, polyembryomas, choriocarcinomas, and one of the most common teratomas, which can either be solid, cystic, and or they can be very highly specialized, developing like a monodermal teratoma when we see it as struma ovariae or carcinoid tumors. So when we see the histological types among the ovarian malignant germ cell tumors, the immature teratomas constitute 35%, and followed by dysgerminomas, which are seen in 32%. Immature teratomas, dysgerminomas, yolk sac tumors, and mixed germ cell tumors constitute 90% of all ovarian malignant germ cell tumors. The clinical presentation of all these germ cell tumors is quite common. Most of them will be asymptomatic, discovered incidentally on ultrasound, or they may present with non-specific signs and symptoms. Sometimes they present as an acute emergency of abdominal pain when they are associated with torsion, rupture, or hemorrhage, and also abdominal enlargement. So some of these tumors, as we know, they secrete SCG, and they can present with precocious puberty, symptoms of pregnancy because of the SCG production by some of these tumors. Fever or vaginal bleeding is seen in 10% of the cases. So the highest incidence is in the second and third decade of life, and the most common is dysgerminoma and the teratomas. So how to go about the diagnosis of this patient preoperatively? So a complete history is very important, followed by examination, imaging, which has already been described by the previous speakers. So we do a transvaginal, transabdominal, transrectal ultrasound, especially because these are unmarried girls. So sometimes you may have to go in for transrectal ultrasound as well. Abdominal CT scans, chest CT scans for lung metastasis, and MRI. A preoperative karyotype is indicated, especially if you're suspecting a dysgerminoma, because some of these can arise in a dysgenetic gonad, which could have a gonadoblastoma, and that can go on to have a malignant transformation, which is seen in more than 40% of the cases. So this is associated with some of the syndromes like Turner syndrome, Klinefelter's, and Swyer's syndrome. Tumor markers are also important for the diagnosis. So whenever you're suspecting preoperatively for ovarian tumor, presence of an adnexal mass on pelvic imaging or an elevated tumor marker should make you think about these germ cell tumors. But the diagnosis of these germ cell tumors is basically made on histology, that is the histopathological diagnosis after surgery. There's only one tumor which can be confidently diagnosed by a pelvic ultrasound, and as we know, that is the benign mature cystic teratoma or the dermoid cyst. These are the serum markers which are associated with the ovarian germ cell tumors. So you see that LDH, which is secreted by the dysgerminoma, and the HCG, which is secreted by embryonal choriocarcinoma. Mixed germ cell tumors can secrete HCG, alpha fetoprotein, and LDH because of the various components it has, and the yolk sac tumor, which will secrete alpha fetoprotein. So it is not only for the diagnosis that you do the tumor markers, but it is also helpful for monitoring response to treatment and for post-treatment surveillance. This is the immunohistochemistry markers, because sometimes even after the surgical excision, it is very difficult to make the diagnosis on histopathology. So immunohistochemistry will also help to confirm the cases. Now, the ovarian malignant germ cell tumors, they typically grow rapidly, and most of them are unilateral tumors, and they usually present at an early stage, that is stage 1. The spread is either by direct extension, hematogenous, or lymphatic. One should remember how to differentiate between the ovarian malignant germ cell tumors and the epithelial ovarian cancers. So we know that it is found in young females. Mostly they are stage 1 disease at diagnosis, and they always carry an excellent prognosis because most of them are chemosensitive. Staging is similar to the one which has been previously been described, that is the FIGO guidelines, and how to go about the surgical staging that has already been spoken. So I'm going to skip on this. This is again the FIGO staging. Now, what are the treatment options? So basically, the first approach is to do surgery. So the surgical management has to be done as a diagnostic as well as a treatment, and the extent of the primary surgery is dictated whether what you find during the surgery, and also consider the reproductive desires of the patient, because they are young, they have fertility issues. So you have to keep that in mind when deciding for the surgical management. So if the lady has completed her childbearing and has no longer concerns of fertility, future fertility, then you go in for the full staging procedure, bilateral salpingo-oophorectomy and hysterectomy. But if she is desirous of having children and is wanting to preserve her fertility, a careful staging procedure, which was previously been described, has to be done along with the unilateral salpingo-oophorectomy. This is for the general germ cell tumors that I'm talking about. So it is very important in all these tumors to carefully evaluate the contralateral ovary. Dysgerminoma, the bilaterality is approximately 10 to 20% of the cases. Most of them are unilateral, but some of these subtypes may have an occasional involvement of the contralateral ovary. So it is very important to do a careful inspection. But any unwarranted biopsies of the ovary is discouraged, especially if it is a normal looking ovary. What about secondary cytoreduction and second look laparotomy? Because these malignant germ cell tumors are highly sensitive to chemotherapy, secondary cytoreduction, the role of cytoreduction in secondary second look laparotomy is questionable. It is not beneficial if the tumor is almost completely resected initially. So the complete resection of the tumor is, if it has been done initially as a primary surgery, then there is no need for secondary cytoreduction or second look laparotomy. But a second look laparotomy may be indicated in those where the disease was not completely resected. Nowadays, we have PET scan and CT imaging with advanced technology, and therefore that also will help in knowing about the residual disease or the recurrence, and therefore the role of second look laparotomy is less. What about radiation? Initially, dysgerminomas were to be treated by radiation. They had good radio sensitivity, good survival rates between 70 to 100%. But now with advanced combination chemotherapy, dysgerminomas can be treated effectively with chemotherapy, because radiation itself will bring down the ovarian reserve, and because these patients are young, therefore chemotherapy is preferred. And the current combination platinum-based chemotherapy for ovarian germ cell tumors is bleomycin, etoposide, and cisplatin. So the chemotherapy management strategies which are used for the malignant germ cell tumors It is given as an adjuvant to the primary surgery and also to treat any recurrence. All patients except those with stage 1A dysgerminoma and stage 1A grade 1 immature teratoma should be treated with adjuvant chemotherapy. So completely resected disease post-chemo can be cured nearly 100%. So on the right side, you can see the various regimes which are used for the ovarian malignant germ cell tumors. Recurrence can happen. All patients with germ cell malignancy, especially early stage disease, who are treated with conservative therapy for curative intent, warrant close follow-up. So how do we follow up them? Every 3 monthly for the first 2 years, because 90% of them will have recurrences in the first 2 years. So you need to do a clinical, radiological, and serological surveillance with the tumor markers. Relapse can be seen, especially sometimes you can see it with the 4 courses of the chemotherapy which has been given. And some of these patients who are platinum sensitive also, they can have a recurrence. And if the patients who have achieved a standard clinical remission of greater than 6 months after completing the BEP regime or another platinum-based chemotherapy comes as a recurrence, then they can be treated again with BEP. So these are the platinum sensitive patients. But those women who do not achieve remission with BEP or relapse within a few months, lesser than 6 months, then these are the platinum resistant and other treatment options to be considered. Chemorefractory cases are the surgical salvage aimed at achieving no residual disease may benefit some patients, and sometimes you may even have to give palliative options. Always remember, because these patients are young and you have to maintain fertility in most of them, so think about the toxicity, and this toxicity can be related to the surgical intervention or to the chemotherapy drugs. So avoid future infertility related to surgery, because you need to reduce the pelvic adhesive disease, because if you are doing extensive surgeries, unnecessary hysterectomies and unnecessary biopsies, it can give rise to adhesive adhesions in the pelvis and can cause problems in fertility. Now, risk of development is also of AML has been seen if you're using etoposide, but it is rare if only 3 cycles are given or less than 2000 milligram per meter square. So this is one of the drugs which is frequently used for ovarian malignant germ cell tumors. So long-term effects of chemotherapy on gonadal function should be minimal. Sometimes, and most of the times actually, there's return to normal ovarian function after you stop the chemotherapy drugs. Risk of ovarian failure is more with advancing age, high drug doses, and long duration of therapy. You can also use some chemoprotective drugs like GnRH agonist, which is given throughout during the chemotherapy cycles, because this will have a protective role on the primordial germ follicles. And once the chemotherapy is stopped, then the ovarian reserve becomes normal. A little about the different types of germ cell tumors. Dysgerminoma, this is a counterpart of seminoma, common in the 2nd and 3rd decade of life, and it is the commonest malignant germ cell tumor. So 80 to 85% of the patients are under 30 years of age, usually diagnosed during pregnancy or puerperium. So 75% of the patients present with stage 1 disease, bilateral involvement in 15 to 20%, and 5% of these tumors have syncytial trophoblasts. So therefore, along with LDH, there can be SCG production as well. So this pathology has already been spoken about. And one thing important which I wanted to highlight again is whenever you're suspecting a dysgerminoma, always do a karyotype, because this can be associated in dysgenetic gonads and therefore the higher incidence of neoplasms, and if there is a presence of a Y chromosome. The tumor marker for dysgerminoma is LDH. This is an algorithm for the management of dysgerminoma. For stage 1A, fertility sparing surgery is indicated, followed by active surveillance. For stage 1B and 1C, you can do a fertility sparing surgery, surgical staging. And if it has been properly staged, then you can go on with the surveillance. If not, then with the BAP cycles. And for stage 2 and 4, you have the fertility.
Ma'am, your time is up.
Yeah, just few more slides. So the mature teratoma, again, we have already discussed about this. And the dermoid cyst, which is one of the most common, it is seen bilaterally in 10 to 17%. It is a slow growing tumor. Complications again are the same: torsion, rupture, infection, and malignant degeneration. So we all know that it has all the three germ cell layers. You can, when you do a cut section of these tumors, you can see the teeth, cartilage, bone, and Rokitansky protuberance is one of the most characteristic feature of mature cystic teratoma. This is an ultrasound of a cystic teratoma. And always be careful while doing a surgery that there is no spillage, because that can give rise to chemical peritonitis. So the surgery which is involved for this is a simple cystectomy. Rarely, if it is large, then you need to do a unilateral adenexectomy. Yolk sac tumors, the serum markers are alpha fetoprotein, and it is the third most frequent malignant germ cell tumor. Highest incidence is around 30 years of age, and it is highly malignant with a poor prognosis. Chemotherapy allows for fertility sparing surgery. So for stage 1 disease, you can go ahead with fertility sparing treatment and followed by chemotherapy. For stage 1C to 4, again debulking surgery is recommended, and you need to give them 3 to 4 cycles of BAP chemotherapy. This is again the same algorithm for yolk sac tumors. Immature teratomas represent 35% of all ovarian malignant germ cell tumors, and the peak incidence is between 15 and 19 years of age, highly aggressive, and they contain all the three germ layers. And again, the pathology may show some of the three ectoderms, endoderm, and the mesoderm elements. Very important is how to grade this on pathology, because grading will depend, the treatment will depend upon the grading as well as the prognosis. So again, pathology of these and grading is important. So for the immature teratoma, again, for the lower grade tumors and stage 1A, you can go in for fertility sparing surgery with active surveillance. Stage 1A, grade 2 and 3, fertility sparing surgery, and surgical staging is required. Stage 1B, 1C, and the higher grades will need debulking surgery. And in some cases, very selective cases, after proper counseling, you can offer them fertility sparing surgery. But then after they have completed their family, you may have to do the full definitive treatment. So embryonal carcinoma is the one which is extremely rare, occurs in very young girls, and the mean age being 14 years. They may secrete estrogen, so they can give rise to precocious puberty. HCG is the basic tumor marker for embryonal carcinoma. Treatment includes staging laparotomy with unilateral salpingophorectomy followed by chemotherapy, and the outcome, 5-year survival, is between 95 to 98% for stage 1 and 70 to 80% for stage 2 to 4. So this is the last, mixed germ cell tumors, which account for 5% of all malignant germ cell tumors. And the tumor marker may again be alpha fetoprotein, HCG, because they have mixed components, and treatment is with chemotherapy depending upon the malignant elements. Prognosis depends upon the size of the tumor and the relative size of its malignant component. So stage 1A, less than 10 centimeter lesions, the 5-year survival is good, approximately 99 to 100%, and for others it is 70 to 90%. So to conclude the take-home points, ovarian germ cell tumors have non-specific signs and symptoms. Always, whenever you are doing an ultrasound, if you find an incidental finding of a solid mass, it must raise the suspicion of malignant germ cell tumors. CTs, MRIs may be helpful, serum markers, but pathology is the cornerstone for the diagnosis of these tumors. Multidisciplinary team may be required. Surgery should be tailored depending upon the age, interest in preserving fertility, and stage of the disease. So the standard treatment is unilateral salpingophorectomy for the young patients in early stages. Surgical biopsy of the normal contralateral ovary is not recommended because this can give rise again to problems in future fertility. But if the patient is premenopausal or menopausal, then you have to go in for full staging and total abdominal hysterectomy with bilateral salpingo-oophorectomy. Platinum-based combination chemotherapy is effective, and even incomplete accession of locally advanced disease, chemotherapy can give long-term survival up to 75 to 80%. If recurrence happens, it is an indicator of poor prognosis. Radiation does not have a role, and follow-up can be done with clinically, radiologically, or by the serum markers. And for now, we should have a national tumor registry and protocol for all these tumors. I'm not sure whether we do have it, but that is the need of the hour. Thank you very much. Thank you, Sarita, for giving me this opportunity, and I would like to thank the ICOG team also because for this opportunity on this platform, it was good to listen to the speakers as well as to present. Thank you so much.
Thank you, Dr. Kavita, for such a wonderful presentation. You have covered everything on germ cell tumor, right from their types, clinical presentations, diagnosis, which is so effective. And also you have told about the how to reduce the toxicity of the drugs. And protocol should be done is a need of an hour. That is what you have concluded. So thank you so much. And once again, Dr. Sarita, thank you so much for
Thank you so much. Thank you. Thank you to all the
we'll have to
speakers
answer
and the
those.
speakers.
Yeah.
Yeah. Thank you. And Dr. Kavita, can you please answer questions in the chat box?
Yeah, I'll do that. Yeah.
Yeah. Okay.
Ma'am, can I
So,
share a post-test link?
yes, yes,
Yeah.
yes. So all those who have missed the pretest can have a chance to actually look at the questions that we had. So can they do those who missed, can they do the test?
Yes, ma'am.
They can? Okay. The link is also posted in the chat box. Okay. So I hope you were able to answer more than 50% of the questions in the post test. So, okay, here are the answers. So we're just going to show you. Can you show the answers, please? ICOG team? Yeah. Can you put it on full screen? Okay. So the questions, the first question, these were given by Dr. Kavita. All are ultrasound features of mature cystic teratoma except lines and dots appearance, tip of iceberg sign, hyper echoic mural nodule, Venetian blind appearance. So this is not a feature of mature cystic teratoma. Chemotherapy regimen for malignant ovarian germ cell tumors most commonly used is. So this, I'm sure all of you know the answer. Most common tumor marker in dysgerminoma, again, very easy. LDH. Next question. Dr. Rama Joshi's questions were, what is the optimal cytoreduction as per GOG criteria? It should be residual disease less than 1 centimeter. Which of the following is the most significant predictor of survival in patients with advanced ovarian cancer? The answer is completeness of cytoreduction. That is the amount of residual disease. Dr. Charanjit questions were, which is the most common tumor marker used for monitoring epithelial ovarian cancer? Again, very simple question, CA125. What is the advantage of using serum biomarker HE4 as a complement to CA125 in ovarian cancer diagnosis? So it is better specific in distinguishing malignant from benign masses. So HE4, especially in premenopausal young patients, it is better because CA125 can be raised in endometriosis as well as in tuberculosis. So HE4 helps you in differentiating. Which of the following statements is true about tumor markers in ovarian cancer? Tumor markers like CA125 and HE4 are part of algorithms for assessing the risk of malignancy in ovarian masses. That is a correct answer. Dr. Subhu's questions were, unilateral salpingo-oophorectomy can be considered in the following. The answer is A, stage 1 dysgerminoma. The largest number of patients with epithelial ovarian cancer is found in, the answer is A, 60 to 65 years age group. Dr. Neeta's questions were, the most common clinical manifestation associated with functional stroma of ovarian tumor. The answer is estrogenic. So the clinical manifestation is usually because of the estrogenic part, which you find in granulosa and theca cell tumors. Then the question, 12-year-old girl with ovarian tumor is reported to have dysgerminoma. Which of the following statements is not true? The answer is alpha fetoprotein is not elevated in a dysgerminoma. The cost-effective method of reducing risk of ovarian cancer and BRCA mutations is risk-reducing bilateral salpingo-oophorectomy. That is the only that is the only procedure that can reduce the risk in BRCA mutations. With ovarian endometrioid carcinoma, the answer is 3, that is CTNNB1. Brenner tumor of the ovary it's a surface epithelial tumor. That is the answer is 2. Question number 16, which procedure is not routinely a part of surgical staging for ovarian cancer? So diagnostic laparoscopy is not a part of a routine surgical staging for ovarian cancer. And it should not be done for ovarian cancer when the mass is suspected to be an ovarian malignancy. What are the steps of surgical staging in correct order? The answer is B. That is first is BDAC, which is opening the abdomen first, and then collecting peritoneal fluid. And just scroll up, please. Scroll up. Okay. And no, just scroll up. No, oh, okay. The next question is how is ovarian cancer staging done? It is surgical pathological staging. That is histopathology, that is, it's a surgical staging, and histopathological. After surgery, it's histopathological staging. GOF symptom index includes all except, the answer is abdominal lump. So it includes, that is the bloating, loss of appetite, urinary symptoms. Abdominal lump is not a symptom in the GOF symptom index. All is true about CA125 except that the answer is B, stage 1, 80% of patients may have elevated CA125 more than 35 international units per ml. So it's 50%. 50% of the patients may have a normal CA125. Okay, so thank you so much to Team ICOG, Dr. Parul, Dr. Sheila, and Dr. Sarita, and all the series conveners, Dr. Parag, Dr. Charmila, and all the speakers and chairpersons, and my coordinator, Dr. Nilanjali, for conducting everything, and the ICOG team for giving us this opportunity and conducting this so smoothly. Thank you once again. Hope you all have a good evening. I think the recording will be on the ICOG website, so you can all access it.